So these are the quadrants. Mohammed, you look here. Not on your phone. You called me from India. C1 screw, C1. You can put the screw straight inside, straight and medial. C2 screw, C2 screw. You have to learn the anatomy on the CT scan, understand how the C2, how the vertebral artery is going, how big is the pedicle, is the vertebral artery high riding, is the vertebral artery medial. So many issues, so many issues. Introducing C2 screw, believe me, today, when I introduce C2 screw, I am almost scared. I am almost scared, very scared. Because in my career of more than 4,000 cases of C2 screw insertion, I have damaged the vertebral artery on several occasions, several occasions. My experience in vertebral artery injury is the largest in the world. Dangerous experience. I know how to handle the situation, but when you handle, you don't have to really, you can have a complication, but if you damage, which you can damage, very rarely you can have a deficit. But if you have a deficit, that is a death deficit. So this technique of one screw here, open the joint, you have to achieve solid arthrodesis. Bone fusion, Atlantoaxial instability is the issue, stabilization and arthrodesis is the treatment. So ultimately you have to put bone in the joint and bone behind in the posterior elements, and you have to do C1, C2 fixation. So this is my position for all my patients, head extended, not head extended, neutral position under traction. It is floating head position. I use iliac crest in all cases and do C1, C2 fixation. I used to use navigation earlier in my career. I don't use navigation now. And of course, for the beginners or for those who are not extremely confident, I'm not saying I'm extremely confident. I'm still telling you when I introduce C2 screw, I am a little bit shaky. I am a little bit, not shaky, I am nervous, even today. But if you have an issue, you can use navigation. Spinous process of C2 and arch of Atlas, huge number of muscles. I want to tell you, this is not the game of minimal invasion. This is not the game of showmanship. It is a game of full big surgery. You do any kind of fixation. If you do not cut these muscles, these muscles are so strong, they can break any kind of implant. So if you do percutaneous and minimal invasion and do not cut these muscles, your implant can never be successful, remember. So when you do have a big exposure, put one screw, open the joint, cut all the muscles of C2, decorticate the bone, put bone graft behind, put bone graft in the joint, and then do fixation. So over the years, I have done many permutation and combination, one screw like this and one like Megal's technique. I call it double insurance fixation. Those are all permutation and combination. Important issue is the vertebral artery. Vertebral artery can sometimes go very medial and you have to be very careful. So understand the vertebral artery, how it goes. And we have done various kinds of preoperative models. You see, this is a 3D model. I can hold the model in my hand and then I see the vertebral artery, then I know where to put the screw. Sometimes the vertebral artery can go deep inside. And if you put the screw, you can hit the vertebral artery. So you have to be very, very careful when you're doing. So these 3D models we introduced a few years ago. Another beauty of the C2 vertebrae is the facet of superior facet and inferior facet. Superior facet is here, inferior facet is here. All other facets are in line. Superior facet here, inferior facet here. But in C2, the superior facet is here and inferior facet is here. And the vertebral artery is here. So if your screw cannot go like this, you can use the inferior facet in a very strong manner. So this is, you can introduce your screw in the inferior facet when the vertebral artery is high. you can introduce the screw in the lamina in the spinous process that I described in 1994. I'll show you. So here you see the vertebral artery is very high riding, and you cannot, if you put your screw, it might be danger. So I have used C2 inferior facet screws. Here also you see there is a big destruction of this part of the bone, and the C2 screw can be a danger, so I have used inferior facetal screws. Vertebral artery, you see sometimes it goes very medial. You can mobilize the vertebral artery, and you please read this article of mine where I describe mobilization of vertebral artery and then introducing this screw. So you see this image, the vertebral artery has been displaced down, if you see here, and the screw has been introduced in the facet. The high riding vertebral artery, I remove this lamina part of this thing, pedicle, and displace the artery down and then put the screw. This is not a very difficult technique. We have also described C2 spinous process screws, C2 laminar screws, and all those kind of screws. So this is my case long time ago in 1992 or 93. We also describe, many of you know these kind of spacers. Open the joint, introduce the spacers. They can be strong and they can be solid, and I call this technique joint jamming technique. I use this basically very rarely now, but this was the thing which we described, introduction of spacers into the joint. Sometimes, if you see this, the C1 facet is very high, and to get C1 screw from here is difficult. So I do a small little craniectomy here and then extradurally expose this C1 facet. I call this transcranial method of fixation. Essentially, if you realize that I do not like to put my screw in the occipital squama, which is very thin, which is 2 millimeter, 3 millimeter. I like to introduce my screw in the C1 facet, even in cases of assimilation of atlas. In any kind of case, I very, very rarely do occipital fixation. So this is vertical instability. You see, this is flexion, this is flexion, this is extension. You see the neck, dangerous, difficult. We introduced this concept of vertical instability. This is mobile instability. You see the facets are disrupted. So we introduced a very beautiful technique which in my view completely revolutionized craniovertebral junction surgery. That technique is open the joint, manipulate the facet, and realign the facet. This concept was never there in neurosurgery. Open the joint, manipulate the facet, and realign. There can be lateral instability, bifid, as we heard just now. Bifid, the facets can go lateral like this. Facetal trauma, tuberculosis can also lead to facetal lateral instability. So in 2004, we introduced this concept that there is not, now please listen to this. There is nothing like fixed dislocation, nothing like fixed. It is mobile, it is pathologically mobile, it is hypermobile. So we introduced this concept that you can reduce fixed dislocation. This kind of dislocation, the whole world was doing transoral decompression, the whole world was doing, some new people have introduced endoscope to remove this, but decompression was the worldwide treatment. We introduced the concept, open the joint, manipulate the facet, and realign. So there is no decompression. And we have got several hundred patients where we have not done any kind of decompression for such huge and complex situation. Now my concept is, this is unstable, stabilization is the treatment, realignment of the odontoid process may not be necessary, is not essential. It is good, but not essential. So this kind of very complex fixed dislocation. Another thing, rotatory dislocation. Nobody in the world knew how to do rotatory dislocation treatment. Nobody. The only treatment was halo fixation, and some people did decompression. Open the joint, learn the art of manipulation of the facet. Difficult. Believe me, difficult. Believe me, dangerous. But you give new life to these people. Not just cosmetic, but hands, fingers, limbs, speech, breathing, everything of these kinds. You can create a new boy or a new girl or a new human being. Dangerous operation. You can bring the odontoid back into line. Basilar invagination, another concept. So my time is running. I know Mohammed is looking at me. Just Mohammed, wait. Basilar invagination, we divided into two groups. One is odontoid going up, second is tonsil coming down. So we introduced this concept, which many of you know, that basilar invagination can be treated by opening the joint, distraction of the facet, and this kind of fixation and realignment. And over the years, we have got several hundred patients where we have not done one bit of decompression, and we have created beauties. We have created, in my own experience, 10 of my patients have become doctors. One of my patients has become neurosurgeon. We have the potential, we have the power to give new life to these very unfortunate people. Learn the art of opening the joint, learn the art of manipulation of the facet, and you can have a different world of craniovertebral junction. I used to do a lot of transoral decompression. I introduced this plate for the first time in the literature, but today, transoral surgery for me, and my message for the world is, it is an historical operation. Thank you very much.
Thank you, Professor Atul, for this very, very interesting change in the concept and the management of this very difficult pathology. And I will give Professor Chlaoui to introduce Professor Etbenali.
Donc, pour la suite, nous invitons Professeur Etbenali de Marrakech pour nous parler du traitement chirurgical de la malformation de Chiari. Donc, comme vous savez, la malformation de Chiari, moi je dirais que c'est peut-être la pathologie qui nous rend un peu divergents, tous les neurochirurgiens, parce que chacun y va avec ses propres convictions, que ce soit pour l'indication, par exemple, pour le grade 1 opéré ou surveillé, aussi pour la technique chirurgicale. Je pense que ça va de la décompression des fois osseuses jusqu'à donc la placie de la durmère, avec donc certaines différences dans les différentes étapes de la technique. Voilà, vous la parole, professeur Etbenali.
Bonjour tout le monde. Je voudrais remercier le bureau de la Société marocaine de neurochirurgie pour la régularité dans l'organisation scientifique de ces journées, de cette école d'hiver. Merci aussi pour le choix pertinent du thème, un thème qui connaît beaucoup de controverses. Je sais que le professeur Atul Goul ne sera pas tout à fait d'accord avec ce que je vais dire là. Personnellement, malgré cet exposé, je suis un peu convaincu de ce qu'il dit. D'ailleurs, c'est pourquoi on l'a invité. I'm convinced by your philosophy, Professor Atul Goul. That's why I invited you to our university, and we are still waiting your visit to Marrakech University. Je vais rapporter un petit peu ce qui se fait dans la littérature. Je pense que la plupart des centres, un peu à travers le monde, font ces techniques de décompression stridurale. Je voudrais aussi remercier le professeur Farouk Ajouji, membre de notre équipe, qui m'a beaucoup aidé pour préparer ce diaporama. Alors, la malformation de Chiari a été le premier à donner ce terme à cette malformation, et il distinguait les malformations Chiari 1, 2, 3 et 4. Par contre, à travers un peu la littérature neurochirurgicale et l'histoire de la prise en charge de cette pathologie, beaucoup d'auteurs se sont rendus compte qu'un certain nombre de malformations ne peuvent être pas rangées dans cette classification, d'où la naissance d'autres classifications. Et il n'y a pas que Chiari 1 jusqu'à 4, mais il faut savoir qu'il y a une autre classification qui distingue toutes ces formes de Chiari. Chiari 1, Chiari 0, 0,5, 1,5, 2, 3, 3,5, 4 et 5. Je vais essayer de faire un exposé rapide par rapport à ces malformations pour avoir un petit peu les nuances, un peu quelques différences de conformation anatomique des éléments nerveux dans ces différentes malformations. Vous savez tous que la malformation de Chiari type 1 est une hernie des amygdales cérébelleuses dans le tronc occipital, mais avec un tronc cérébral en position normale. Et elle peut être associée à une syringomyélie. Et ce qui arrive, bien évidemment, doit être différencié d'autres causes de descente des amygdales cérébelleuses dans le tronc occipital, notamment les chiari acquis suite à des processus de la fosse postérieure, ou alors des cas qui surviennent dans le cadre d'une hypertension intracrânienne. Donc ça, c'est le chiari 1. Donc, mon collègue radiologue, professeur Fikari, a brillamment exposé ça. Le chiari, c'est quand la descente des amygdales dépasse 5 mm au-dessus du plan du trou occipital. Entre 3 et 5, c'est un peu borderline. Et il faut surveiller ces malades parce qu'elles peuvent évoluer par la suite. Et si c'est associé à une syringomyélie, il peut être considéré comme pathologique. Alors, qu'est-ce que c'est que la malformation chiari 0? C'est une malformation qui associe une syringomyélie, mais sans ectopie des amygdales cérébelleuses dans le tronc occipital. On a tous vu des dossiers comme ça, syringomyélie sans chiari. Donc, c'est ce qu'on appelle le chiari 0. Et l'explication de la syringomyélie est le suivant. Il y a très souvent des adhérences arachnoïdiennes avec un petit volume de la fosse postérieure qui explique un peu cette gêne à la circulation du LCR et la constitution d'une cavité syringomyélique. Qu'est-ce que c'est que le chiari 0,5? Il est reconnu comme étant une variation de la forme chiari 1 avec un aspect ectopique des amygdales, comme vous pouvez le constater sur l'IRM, un aspect ectopique antérolatéral des amygdales cérébelleuses. C'est bien vu sur l'IRM, c'est un chiari 0,5. Alors le chiari 1,5, c'est aussi une variété du chiari 1, et il consiste en une hernie des amygdales cérébelleuses avec le tronc cérébral aussi, et l'obex, et il s'y associe un complexe de malformations importantes de la jonction, notamment l'impression basilaire, etc. Le 2, c'est une myélodysplasie avec hydrocéphalie. Alors là, vous avez l'hernie des amygdales, le tronc cérébral, le quatrième ventricule, et ça c'est souvent une syringomyélie. Le 3, c'est le plus rare et le plus sévère des malformations du chiari. Il y a une hernie du cervelet, du tronc cérébral, et puis c'est la forme qui a le pronostic le plus sombre, et en général les malades meurent, sinon ils gardent des déficits neurologiques un peu sévères. Le 3,5, c'est une variété du chiari 3 avec une encéphalomyélocèle. Voilà. Puis 4, dans le 4, il y a une hypoplasie du cervelet, et puis il s'associe à d'autres anomalies, l'ectopie des amygdales. Il n'y a pas de faux du cervelet, il n'y a pas de tond du cervelet, une petite fosse postérieure, un trou de foramen magnum très étroit. Voilà. Le 4, c'est carrément une absence du cervelet. Le 4, c'est le lobe occipital qui descend dans le trou occipital. Le lobe occipital dans le trou, il n'y a pas de cervelet. C'est une malformation très rare et sévère. Alors la syringomyélie, les auteurs ont distingué différents types, 1, 2, 3 et 4. Je vais être un peu rapide parce qu'il faut que je passe un peu à la chirurgie. Il y a le type 1, c'est l'obstruction du foramen magnum. Le type 2, il n'y a pas d'obstruction du foramen magnum. Le type 3, c'est quand il y a une pathologie associée, tumeur, traumatisme, arachnoïdite post-hémorragie méningée, etc. Et le 4, c'est l'hydromyélie. Alors, bien sûr, dans la prise en charge de ce chiari, il faut tenir un peu compte, comme ce que vient de dire le professeur Atoul, d'un certain nombre de facteurs modifiants, ce qu'on appelle les modifiers, notamment les problèmes de la circulation du LCR. Il faut savoir s'il n'y a pas une hydrocéphalie, s'il y a une ventriculomégalie, est-ce qu'il y a une hypertension intracrânienne. Les problèmes un peu de fosse postérieure, les craniosténoses, des problèmes de veine, de drainage veineux, et puis un conflit contenant-contenu, petite fosse postérieure, le volume de ce qui entoure les amygdales et le cervelet, et puis la taille de l'os occipital aussi, c'est un élément anatomique à analyser. Toujours dans le cadre de ces modifiers, donc les problèmes locaux, les anomalies biomécaniques, l'impression basilaire, la simulation de l'atlas, et puis enfin les problèmes de croissance, du métabolisme phosphocasstique peuvent générer des malfonctions de la charnière qui peuvent stimuler aussi, interférer dans la prise en charge de ce qui arrive. Alors, c'est cette plaque, c'est mentionné un petit peu les différentes causes des ectopies amygdaliennes. Il y a les malformations, mais il y a les causes non malformatives, notamment ce que je viens de dire, les potentiels intracrâniennes, la craniosténose, le volume cérébral du cervelet, etc. La moelle bas attachée, tout ceci peut concourir à entraîner une ectopie des amygdales cérébelleuses dans le trou occipital. Les buts de la chirurgie ou les indications de la chirurgie, c'est en général quand il y a une syringomyélie, c'est indiscutable, il faut opérer. Et puis quand il y a un déficit neurologique, et les buts de la chirurgie, c'est d'assurer une décompression de la charnière cranio-rachidienne, surtout lever le problème de la circulation du LCR, restaurer un flux normal dans le trou occipital pour espérer réduire le chiari et la syringomyélie s'il accompagne cette malformation. Et puis, bien sûr, la stabilisation quand il y a une instabilité, comme ça vient d'être expliqué brièvement par le professeur Gaulle. Différents types de chirurgie. J'ai dit tout à l'heure, c'est un thème très controversé, parce qu'il y en a qui font juste la décompression osseuse, il y en a qui ouvrent la dure mère, il y en a qui ouvrent la dure mère sans ouvrir l'arachnoïde, il y en a qui font le tout jusqu'à libérer l'obex, etc., avec la duroplastie. Donc les techniques sont très variables. Dans la littérature, il y a un certain nombre de détails qui ne sont pas traités, qui ne sont pas discutés dans la littérature. C'est la taille de la craniectomie, la taille de la laminectomie. Il y a rarement des publications qui traitent un peu de ça. Le type de duroplastie, péricranium, synthétique, etc. D'autres aspects sont également très discutables. Arachnoïdolyse ou pas, ouvrir l'obex ou pas, ventriculostomie, drainage du quatrième ventricule, coagulation ou pas des amygdales cérébelleuses pour faire un peu de la place pour permettre une bonne circulation du LCR dans le tronc occipital. Ça, les articles que j'ai pu revoir un petit peu ne traitent pas beaucoup de ça. Les étapes de la chirurgie, c'est la décompression externe, ouverture de la dure mère, décompression interne, duroplastie, puis fermeture. En imagerie, ce qu'on voit parfois aussi, c'est qu'on peut parfois voir des lésions d'ischémie dans la partie basse du cerveau, des amygdales cérébelleuses, comme c'est montré ici dans cette plaque. Et on peut les constater en péropératoire. Vous regardez l'aspect des amygdales cérébelleuses, un peu pâle. Ça, c'est des lésions d'ischémie dû à une compression chronique. Même chose dans cette plaque, on les voit ici, l'ischémie. Parfois, on peut avoir même des formations de certains kystes. Voici les différentes étapes de cette chirurgie. Craniectomie décompressive, ouverture de la charnière, coagulation, rétraction des amygdales. Sur la troisième photo, libération de l'obex pour s'assurer que le LCR circulaire remonte, puis une plastie d'agrandissement. Alors, bien sûr, le professeur Goula a beaucoup insisté sur l'instabilité. Chaque fois qu'il y a une instabilité, il faut absolument la traiter. Et on peut faire un abord antérieur pour les gens qui en ont l'expérience pour réséquer l'odontoïde sur des déformations en flexion fixées et irréductibles. Il faut aborder un peu le réséquer l'odontoïde, soit par voie chirurgicale ou par voie endoscopique pour les gens qui en ont l'expérience pour décomprimer la charnière. Quand il y a une instabilité, comme ça vient d'être expliqué par le professeur Goula, il faut faire une fixation C1, C2 pour traiter l'instabilité. Je pense qu'il a brièvement discuté de tous ces aspects d'instabilité de cette charnière. Les fixations occipito-cervicales, on peut chez certains malades les faire aussi. C'est un cas aussi de service avec une malformation du carré, céphalée, vertige, etc. Ça, c'est le scanner. Le scanner qui ne montre pas une compression très importante. Le cliché dynamique, ça n'a pas trop bougé. Et donc, comme la plupart des neurochirurgiens, on a fait une technique un peu conventionnelle de craniectomie décompressive, ouverture de la dure mère, libération de la charnière, puis plastie d'agrandissement, comme illustré ici. Je pense que dans la littérature, ce qui est rapporté, c'est un peu cet algorithme de prise en charge, en fonction un peu de l'étiologie. Quand le carré est asymptomatique, qu'il n'y a pas de syringomyélie, il faut surveiller. Quand il y a une syringomyélie, il faut surveiller, quand il est asymptomatique, mais avec une petite cavité syringomyélique, on peut toujours surveiller. Si le patient est symptomatique, avec au son syrinx, et qu'il y a une hypertension intracrânienne, en cas d'hydrocéphalie, il faut traiter l'hydrocéphalie, soit endoscopie, soit VCS, soit une valve. Quand il y a une craniosténose, il faut la traiter. Si maintenant il y a des anomalies de la charnière, il faut faire une décompression de la charnière. S'il y a une stabilité, il faut fixer. Et s'il y a une cause métabolique, une pathologie métabolique, il faut lui opposer le traitement approprié, comme ce que vient d'expliquer Mme Fikri, qui nous a montré un peu un éventail de pathologies de cette région. Par rapport à l'invagination, si un carré sans invagination, sans instabilité, c'est la décompression peut suffire. Quand il y a une instabilité, il faut décomprimer et fixer. S'il y a une invagination avec une compression ventrale, il faut voir un peu la fonction des nerfs crâniens. On peut faire aussi une décompression puis une stabilisation, une fixation. S'il n'y a pas de compression antérieure et qu'il y a des anomalies de la segmentation, là aussi il faut fixer. Sinon, il faut faire simplement une décompression de la charnière. Donc, c'est des algorithmes un petit peu qu'il faut adapter au cas par cas. C'est un guide un peu pour orienter un peu le geste à opposer à ce genre de lésions. Il y a des consensus, un groupe de travail sur ces consensus de prise en charge de malformation de carré, et se sont posés un certain nombre de questions, illustrées ici, et même les experts ne sont pas tout le temps d'accord. Donc, vous voyez que les pourcentages d'accord par rapport à chaque geste d'indication de la chirurgie, de décompression osseuse uniquement, de l'abord d'ouverture de la dure mère, de la place, etc. Même les auteurs ici, d'après ce consensus, ne sont pas tout à fait d'accord. Et les pourcentages de consensus et d'accord varient de 60 à 90%. Donc il n'y a pas l'unanimité. Ce qui justifie encore une fois la pertinence de ce thème qui est un peu complexe et qui continue à susciter beaucoup de points d'interrogation. Même chose. Je termine par cette diapositive, c'est la dernière diapo. Quand on a un chiari, il faut bien sûr le tableau clinique. La chirurgie recommandée chez les patients symptomatiques ou alors chez les patients chez qui il montre une progression. Chez la population pédiatrique, les auteurs recommandent simplement une décompression osteo-ligamentaire. C'est tout, chez l'enfant. En général, les choses s'arrangent. Bien sûr, s'il y a une instabilité, comme vient de dire le professeur Goul, il faut opérer. La question d'ouverture de l'arachnoïde et de la désiolyse se discute. Et puis, c'est beaucoup plus indiqué chez les patients déjà opérés, anciennement opérés. Et la coagulation des amygdales peut permettre de faire de la place aussi, mais il y a aussi, il ne faut pas trop coaguler parce qu'il y a un risque aussi de créer des lésions d'ischémie. Et l'instabilité à l'axe nécessite une fixation. Voilà, j'ai fait un petit peu une revue de la littérature un peu sur ce qui est fait sur cette pathologie qui suscite encore beaucoup de controverses. Sur ce, je vous remercie.
Merci, professeur Ismaili, pour cette belle présentation concernant la technique chirurgicale dans la prise en charge de la malformation d'Arnold Chiari. Donc, on invite le prochain speaker.
Donc, another second round, Professor Atul will give us a new concept, a new insight, this central or axial and atlantoaxial instability. Donc, go on, Professor.
I am going to introduce to you a revolution in craniovertebral junction surgery. Relax and enjoy. Don't get stressed, okay? But be ready for a revolution in craniovertebral junction surgery. I wish to introduce to you, my dear friends, a new concept of central or axial atlantoaxial instability. You remember when I say craniovertebral junction instability, I mean atlantoaxial instability. A fantastic concept for you. Not just craniovertebral junction, compression is not the issue. Compression is always secondary. Compression is always reactive or protective or adaptive. Compression indicates unstable spine. Decompression is never the treatment. Compression is reversible after stabilization. So these statements you please remember for my next two lectures. Compression is not the issue in spine surgery, and decompression is not the issue in spine surgery. You please remember these sentences. I wish to introduce to you a concept of vertical facetal instability. This I will talk in my next lecture. In this lecture, I want to talk on central or axial, atlantoaxial instability. I wish you please read this article in Neurosurgical Focus, where we have discussed a large number of patients having central or axial instability. Atlantoaxial joint is the most mobile joint. Atlantoaxial joint is a flat joint, flat. All other joints, occipito-atlantal joint is like a cup joint, cup. Atlantoaxial joint is a flat joint. As I discussed last time, for fixed dislocation, for irreducible dislocation, decompression was the treatment. We said that this is not fixed, this is unstable, this compression is not the issue, instability is the issue, realignment and stabilization is the treatment. For basilar invagination, we said, in 2004, we divided into two groups, one odontoid going up, one tonsil coming down. So for this group, we said that craniovertebral junction realignment is the treatment. In 2004, we said for group B, foramen magnum decompression is the treatment. This is in 2004. In 1999, we said that basilar invagination is nothing but facetal listhesis, C1 over C2 listhesis. Listhesis is unstable, stabilization is the treatment. Like here, basilar invagination, Chiari malformation, syringomyelia, listhesis is the issue. Listhesis. In 1999, so 25 years ago. Decompression is not the treatment, stabilization is the treatment, and realignment is the best clinical outcome. You see here, it is in realignment. So there is no role for decompression. So basilar invagination, we have treated, as I mentioned, several hundred patients without any kind of decompression. The concept is, compression is not the issue. Instability is the issue, stabilization is the treatment, and realignment is the best possible outcome. So this kind of basilar invagination, compression is not the problem, stabilization and realignment are the treatment. And all these things which look compressive by odontoid process, by tonsil, by syringomyelia, they are all secondary and they are all reversible. When there is chronic atlantoaxial instability for 20 years, for 25 years, nature comes in picture. Nature. And repairs the bones, repairs the soft tissues, repairs the neural structures. My dear friends, I wish to introduce to you this concept of central atlantoaxial instability. This instability is present in Chiari malformation, in syringomyelia, in OPLL, in degenerative spine, in Hirayama disease, and many other issues. So let me talk about it. So when there is chronic atlantoaxial instability, this is the genesis. This is the nodal point of genesis. Chronic. Remember this word chronic. And when there is chronic instability, this is the father. This is the father. And this father produces many children like Chiari malformation, syringomyelia, C2-3 fusion, assimilation of atlas, Klippel file abnormality, external syringomyelia, basilar invagination, OPLL, bifid C1, os odontoideum, and all these and many more. So all these things that you are seeing, all these things are secondary to chronic atlantoaxial instability. That is one. All these things that you are seeing are secondary. All these things that you are seeing are protective. All these things that you are seeing indicate instability. You do stabilization and all these things are reversible. So this is a huge concept in craniovertebral junction surgery. As I talked in 1999, listhesis of C1 over C2 is the issue, basilar invagination is the problem, instability is the issue, stabilization is the treatment, there is no role for decompression. This is 1999. Then we said that there is basilar invagination, there is no compression, there is no atlantodental interval disturbance. Look at the facet. There is retrolisthesis of the facet. Instability is the issue and stabilization is the treatment. The whole world today will do decompression for such an issue. With Chiari and syrinx, with basilar invagination, decompression. My concept is 100% clear that decompression is not the treatment. This is unstable. Stabilization is the treatment. Third thing is, even when the facets are in alignment on lateral profile imaging, even when there is no atlantodental interval disturbance, presence of assimilation of atlas, presence of basilar invagination, presence of platybasia, presence of Chiari, presence of syrinx, who are all children of father atlantoaxial instability. Atlantoaxial stabilization is the treatment, and there is no role for any kind of decompression. So basilar invagination, syringomyelia, Chiari malformation, whether they are present together or whether they are present discretely, they indicate unstable atlantoaxial joint, and stabilization is the treatment. You will agree that this is a completely different concept from what is followed throughout the world. So this article of mine in 2013, is atlantoaxial instability the cause of Chiari, and is atlantoaxial stabilization is the treatment? This created quite a bit of confusion in the world of craniovertebral junction. Today, if you ask me, I don't agree, oh, I don't believe, I say go to nonsense hell if you don't believe. This is the thing, this is the treatment. If you don't want to learn the C1, C2 fixation, if you don't want to understand C1, C2 fixation, and unnecessarily argue, no, we don't believe or don't believe. There is one answer to that question is, come to Mumbai and spend few weeks like many people in the world have come. There is no reason why Moroccan neurosurgeons cannot come. Morocco is not far away. The culture is the same, the food is the same, the people are the same. Come to Mumbai and enjoy craniovertebral junction. But don't argue with me. So basilar invagination, the whole world was saying 20 years ago that decompression is the treatment. Now I say without any confusion, instability is the cause and stabilization is the treatment. And we have produced several articles in the literature. Whatever statements I'm making are all published in very heavy journals. This is in World Neurosurgery. Group A treatment with so many patients. Group B for no decompression, only stabilization. So CAD means central or axial atlantoaxial instability. We divide into 3 groups. Group A is when there are craniovertebral junction issues like platybasia, basilar invagination, syringomyelia, C2-3 fusion, assimilation of atlas, group A. Group B is when there is only CAD, no problem in the craniovertebral junction. Group C is when there is degenerative spine, OPLL, Hirayama disease, which I am going to talk in the next lecture. Now this is the patient, there is no atlantodental interval disturbance, there is Chiari and syrinx. There is no problem here. You do atlantoaxial fixation and you see the magic in the evening of operation, not after 1 month, not after 2 months. In the evening of operation, you give new life to this person. This person who will come with tingling in hands, weakness in the fingers, difficulty in talking, pain here for 10 years, difficulty in walking, kyphoscoliosis, short neck, torticollis, all these issues are secondary, they are protective, they are reversible. See, there is basilar invagination, assimilation of atlas, no problem here. The treatment is, there is Chiari and there is syrinx. There is no syrinx here, but basilar invagination, they are children of one father, that is atlantoaxial instability. The syrinx will reduce. Syrinx will reduce in 100% of patients if you have done a solid fixation. Open the joint, put bone graft, do fixation. Whether the syrinx recovers or not recovers. Please remember this statement. Whether the syrinx reduces or does not reduce is not the issue. Issue is the patient should recover not marginally, remarkably. New life in the evening of operation. You remember my words. You see all these words are very heavily published. You see this is syrinx, this is Chiari, the syrinx, this is on the 3rd day of operation. And this is after 6 months of surgery. I will not say in the 3rd day every patient the syrinx will reduce, but after 3 months, 100% patient, the syrinx will reduce. Reduction of the syringe is not the issue. Improvement of the patient is the issue, and patient will have a new life instantly. Basilar invagination, Chiari malformation, syringomyelia, no problem here. There is kyphoscoliosis. The treatment is C1, C2 fixation. There is no problem here, no problem here, no problem anywhere. There is syringomyelia. You do fixation and you see magic. You see a magic that you have not realized in your career of neurosurgery. And this is published in World Neurosurgery, 300 and so many cases. Now my experience is nearing 600 cases. Now, you know, if somebody argues with me, I just say, ignore. Because I'm completely sure, completely confident that Chiari malformation, the treatment is here. The pathology is here. Learn the art of fixation of C1, C2. Learn the complexity. Another beautiful thing I want to say, Mohammed, to do C1, C2 fixation in the presence of basilar invagination, in the presence of syringomyelia, in the presence of clipal file abnormality, C1, C2 joint is much up, rostral. To do C1, C2 fixation is not easy. Venous bleeding can be heavy and quite a bit, but that is the treatment. If it is difficult, does not mean it is not the treatment. All these things which I mentioned are secondary, they are protective. So I have removed the word Chiari malformation and I use the word Chiari formation. I have removed the word craniovertebral junction anomalies. I have introduced the word craniovertebral junction alterations. And I have got several patients. You see this tonsillar herniation, see the facet. This is clearly unstable. You do fixation. There is little bit instability. You do stabilization. Syringomyelia will reduce after. Other child, clipal file, assimilation of atlas, C2-3 fusion, short neck, torticollis, they are also children of the same father. Cervical fusions are protective and they are due to unstable atlantoaxial joints. So this girl looks very ordinary girl, but a daughter of very big politician in India, big politician. She came to me in a miserable condition, not able to talk, not able to breathe. And after surgery, this girl became a new girl. You see, there is no compression here, no compression. But you see, there is a problem here in the C1, C2. I did C1, C2 fixation, and I instantly became very popular in the country because this politician made me very, he just advertised my name everywhere in the world. C2-3 fusion is not a congenital anomaly. It is secondary and protective. Assimilation of atlas is not a congenital anomaly. It is secondary, it is chronic, it is protective. So when you see a clipal file anomaly, multiple fusion, compression here, this is not the problem. This is the solution. Compression is not the issue. The problem in spine surgery today is we look at MRI, we look at the compression, decompression. This is the problem in spine surgery, which is the major, huge problem. This patient does not need any treatment here. This patient needs C1, C2 fixation. Bifid is not a congenital anomaly of embryogenesis or anything. It is secondary. It is protective. The facets go lateral. Why the facets go lateral? You read this article in neurosurgery. It is a protective natural phenomenon. So when you see bifid, when you see multiple bone fusions, don't look here and don't look there. It is C1, C2 instability. Stabilization is the treatment. You go anywhere in the world. My promise, you go to US, you go to Germany, you go to France, the only treatment will be decompression. I'm saying it is a negative form of treatment. I'm sorry, my dear friend, just enjoy and relax. Don't worry. Os odontoideum is secondary. It is naturally protective. It indicates C1, C2 fixation. Today you read the Western literature. Many people do decompression for this. You see Western literature, they do occipitocervical fixation for this. Not good. It indicates C1, C2 instability. It indicates the need for C1, C2 fixation. Occipital bone is like mother. It is protective. It loves the neural structures. Don't put holes in your head of your mother. Just do this dangerous operation, this difficult operation. Syringomyelia. In 1995, I said syringomyelia is never a problem. It is solution. It indicates something else. You find that something else and treat that something else. Do not touch the syrinx. And there are several articles of mine on this subject. Idiopathic syrinx, another issue, idiopathic syrinx. I said all these secondary things which I have said when they are present, like Chiari and syrinx are together, Chiari, basilar and syrinx are together, only Chiari is present, only basilar there, only assimilation of atlas, only clipal file, only syringomyelia, C1, C2 is the fixation, is the treatment. And believe me, just believe me, my dear friends, you give new life. And that new life is in the evening of operation. Enjoy that new life. I introduced this concept of external syrinx. When you see more fluid here, this is also like internal syrinx and external syrinx are the same. Here there is more fluid. This more fluid is external syrinx. Here there is external syrinx. Here there is internal syrinx and external syrinx. There is no difference in all these things. Short neck. When you have a herniated disc, the patient goes like this. Why he goes like this? Tell me. Because it is a protective phenomenon. Why he gets spasm? Because it is a protective phenomenon. Similarly, short neck, torticollis, these are natural. Long stenosis, you get short neck, and then there is a fusion. So all these things are indicators of unstable spine, and all these things, you create a new neck, you give a beautiful new smile, you give new hands, you give new voice, you give new breathing in the evening of operation. Mark my word, when I say evening of operation and all those things, they look very egoistic. They look very hyper. They look like nonsense. But believe me, this is the result of these operations. So this short neck, short head. So my time is getting a little bit faster because whatever. So this kind of beautiful people you can create. This kind of kyphoscoliosis, beautiful, beautiful kyphoscoliosis. You see kyphoscoliosis, you take your screws and start introducing big rod and big screws. But remember, in this age, many of these patients have central instability. You treat central instability. There is no need to do anything to this, and this patient will recover very quickly. And there are so many things. Now, if I have time, my dear chairman, I want to introduce one beautiful thing. Should I, or maybe no? Mohammed, 2 minutes is too much. But listen. So I have got several patients now. You read this title. And this patient comes to me with this kind of implant and having for 10 years, he was being treated by psychiatrists, by medication, he lost his job and all those things. There is no problem here, no problem here. No compression here. So this is the way he is walking, okay? I do rotatory scan, rotatory imaging, dynamic rotatory imaging. You see the facet of C1 and C2? Completely disrupted, completely. So I call it rotatory dynamic imaging. I do C1, C2 fixation in the evening of operation. Mark my word, evening of operation. You see this. This patient is, now you see here how he is running, and I also introduced this image. So I give a new life to this person. Whatever you are watching is just very superficial, but his pain in the hands, fingers, this and that, too many things. Another patient I show you. This patient from another country comes to me with this kind of, you see here. You see, this is the husband and this is the wife. And you see how the husband is ready to catch like this. You see? Do you see? Like, ready. Very good husband. Nowadays you don't get such husbands. You see this? And you see there is no compression here, no problem here, no, I do rotatory scan, rotatory dynamic scan, and you see when the patient is still in the ward here, and you can see this new life, and you see this beauty. And I have got several patients like this, and I want to just say thank you very much, my dear friends, to invite me. And I had some more slides. Last slide, because 2 minutes, some few minutes are remaining, few seconds. Now there is no compression here, okay? No compression here. There is some syringomyelia, okay? What you do? Tell me what you do. There is no problem here. There is bifid here. Tell me what you do. Thank you very much.
Thank you, Professor Atul, for this wonderful presentation. It's almost a great pleasure to hear you giving this lecture. Donc, on va se permettre 15 à 20 minutes maximum de questions. J'imagine que le débat sera très intense, donc on attend vos questions. Oui. Professor Aldéan.
Very nice talk, and I'm quite convinced that you are right in many cases. But how do you explain that the classical decompression, osteodural decompression, still works?
I have to tell you one thing, which you have not read. I was the first one in the literature to introduce the concept that Chiari is due to tight posterior fossa. I introduced this concept in 1998 in Journal of Neurosurgery. I introduced this concept that there is no need to open the dura. And many people follow this concept, many people do not follow. So I introduced this concept. I introduced another article where I said you don't open the dura, you reverse the occipital bone, and I call it foramen magnotomy. So I introduced this concept, what you said. But I changed my own concept. I said my concept is not correct. So you please remember, you are not giving me new information, you are taking my information. Yes, now this question is very important, and this is question, I believe me, everywhere I give my lecture, this question is the first question that they ask. Like, I have been doing foramen magnum decompression and my patients are improving. But I have to tell you that improvement, I have now done over 100 patients of failed foramen magnum decompression of my own cases and other cases. Your improvement, you take an incision, you must tighten the muscle and closure the muscle. There is pain post-operatively. There is stiffness post-operatively. Immediately after operation, second day after operation, he will say, yes, there is some improvement. You show me any patient after 6 months. I can say I have been doing and I have written several articles on dural decompression. And now I am saying that this is an improvement which appears to me as a temporary improvement. These patients will never improve. Chiari malformation is a chronic disease, is a relentlessly progressive disease. They start with finger problem, they start with weakness, then they get stiffness of the legs, pain here for a long period of time, restriction of neck movements for a long period of time, then they start getting voice disturbance, then they start getting breathing problem, then they start getting sleep apneas. They slowly, over 10 years, over 15 years, they go down and they die a miserable death. Like in COVID, during COVID times, what used to happen is they were not able to breathe.
I think we don't see the same Chiaris.
You don't see me, even in chimpanzees, the carry is the same. We have treated chimpanzee with C1, C2. Discussion later during tea time.
One more question.
Yes.
Which is the rate of vertebral artery injury you announce your patients? Because it's also a question of complexity of the procedure.
See,
I think the osteodural decompression is associated with a rather low morbid mortality. I agree with you that the postoperative course is always quite difficult. People have stiff neck, they have some pain, but they don't have a 10% risk of vertebral artery injury, which, as far as I know, is best hands rate announced in the literature. So I for myself, if I have a Chiari, I will take the imperfect procedure against 10% risk of vertebral artery injury. And I suppose if you do some statistics in this conference room, I think most of the people would say the same.
see, this is not a political issue. I don't want to make a vote for me or don't vote for me. Most of the people will say, no, I don't agree. This is not a political, I'm not a politician. I'm not giving a political lecture. I'm giving what I feel and what I have published. You read my articles about complications, about vertebral artery injury, this incident. Only advantage for me is that I'm in this area since 1987. I have done more than 4,000 cases. I can smell instability during operation. I can feel the instability. I'm not saying I don't have vertebral artery injury. I'm not saying that I have never had a complication. Did I say that? I have never had a complication. Did I say that my fusion has always been successful? All these issues which you are saying that there can be problem, there can be this, of course there can be problem, but this is the solution in my mind, in my absolute mind. And I am inviting everybody. I have got several visitors all the time from all over the world. I have invited people from Morocco. I am inviting you from France. And you come. And you don't keep ego in your mind. And you don't keep, no, I cannot come. I believe in this. Vertebral artery can get damaged. Complication can happen.
Professor,
Don't.
I think you are right in many cases, but most of the cases you show, there are Chiaris with some instability associated. Actually, in my practice, these are a minority because we constantly do dynamic X-rays, and I know you will tell me that sometimes dynamic X-rays don't show instability, but most of the cases you showed had instability, obviously instability associated to the Chiari. It's not the case for all Chiaris.
I am saying for all Chiaris. I am saying for all, I'm not saying spina bifida and Chiari. I'm not saying hydrocephalus and Chiari. I'm not saying tumors and Chiari. I'm saying Chiari, syringomyelia, craniovertebral, even when there is no there is one article of mine. See, the beauty is all my statements are published. There is one article of mine where I'm saying there is no bone abnormality in Chiari and C1, C2 fixation. Over the years, as I mentioned now, I have got more than 600 patients. If somebody argues with me, I will, with due respect, I know your work, and you have given me such nice that you have been reading my articles and this and that, but unfortunately you did not read between the lines. So please go home and try to feel. I know it is different. I said it is a new world of craniovertebral junction. Try to feel what I'm saying and try to read what I have written. And if you have issues, I'm available with you. I can come. I went to Morocco in his department. I come to France. I can operate with you. Chiari,
With pleasure.
No, please, one thing I can tell you. Please don't, this is not a political forum. We are not leaders, we are students, okay? Remember this. I am giving you a new format of treatment. I am giving you a new concept in craniovertebral junction, where I am saying, if you see a patient with only C2-3 fusion, nothing else, you see only C2-3 fusion, do C1, C2 fusion. If I am saying, which I did one case with Mohammed, just this clipal file abnormality, nothing else, no compression, nothing else. I did C1, C2 fusion. If you see a patient with short neck, if you see a patient with torticollis, if you see a patient, another thing, idiopathic syringe. I have got at least 20 patients now in my series, where the person comes miserable with weakness here, weakness there, and there is a syringomyelia, small syringomyelia. What do you do? Do you open and put a tube in the syringe? Do you do some kind of decompression? You have to just, you see, I cannot now say more than what I'm saying. You can have the possibility of a magic new life. You do C1, C2. Understand this concept. Try to image lateral profile, rotatory scans. Now I'm doing much more elaborate imaging, but for several years I was just doing lateral profile, seeing the facet. Over the years, then I stopped doing lateral profile also. I am convinced that this is unstable. You do stabilization. After seeing, another thing I'll tell you, and you have to believe me, on my phone, there are more than 600 audios. Every patient, I take a video after the surgery, where I'm saying, how are your fingers? How are your hands? How is the stiffness of your legs? These are my questions. How is your voice? How is your sleep apnea? How did you sleep in the night? And my last question is, to the mother or the father, has your son or your daughter got a new life? I've got 600 yes. So you can, I can have arguments, I can have discussions. But this is what, if I'm saying lies and if I'm saying nonsense, that is another thing. But this is between you and me. Forget and Mohammed.
Merci, merci,
Okay.
professeur Atoul, professeur Louahabi.
Thank you, Professor Toul, for coming the second time in Morocco. 20 years ago, we have been in Marrakesh in the World Congress, and we were that time honored to accept our invitation. Now I thank you. You see Marrakesh with a very hot temperature. Now it's very cold here, so Morocco has diverse, and the climate is so different. I have attended many meetings where you have been presented many new concepts about craniovertebral junction malformation, and every time there has some discussion behind the scene during the breaks. I have two questions, because we have many colleagues here are young, and I want that we can come at the end with, you have been so precise in your concept. So two things. The traditional teaching, when we have a craniovertebral junction malformation, we go to look for instability or instability by dynamic CT, etc. Let's suppose you have a case with basilar impression with fixed and compressive lesion. We go with the traction that doesn't work, we go with CT, doesn't work. Do you think this case you have to go for fixation? It's always in our mind fixed. This is my first question. The second question is, your concept is very important to try to gather many let's say consequences on the same one father, as you say. Did you have any, in your experience, for example, cases that have been diagnosed with instability, let's say in children, that you followed without fixation and they developed this kind of malformation? I don't know if you see my idea. Thank you very much for coming. Thank you.
Now let me answer your first question. When there is basilar invagination and there is a fixed anomaly and there is compression and the patient has deficits, what we do? So this concept in 1994, no, 2004, not 94, 2004, the whole world, if you know people of this age group, every conference in the world on craniovertebral junction surgery, there was a big session on how to do transoral surgery. Every conference, even in Marrakesh, there was a full session on how to do transoral surgery. You please see the program, I tell you. Every meeting in the world, there was a session on transoral surgery, how to put implant this and how to do decompression, how much to remove, whether to remove the dura, how to remove the ligament, tectorial membrane. This was constant. My feeling, whether somebody agrees or not agrees, we created a revolution in this subject, saying that this is not fixed, this is not irreducible, this is hypermobile. You open the joint and see the unstable this thing. Instability is the issue, stabilization is the treatment. So that is my answer to your question. Even if you don't see instability, does not mean it is not unstable. These are unstable. When there is odontoid going up, this is unstable. When there is basilar invagination, this is unstable. So this is one thing. And second thing is, really, I didn't understand your question properly, but instability is the issue in Chiari, whether it is in children. When I wrote this article in 2013, it was published in Journal of Neurosurgery. Jim Rutka was he's still the editor of Journal of Neurosurgery. I wrote this article, and there were several correspondence. You read in, there are letters to editor to me, many letters to editor. And some letters saying, listen to this. This is in Journal of Neurosurgery. Like you said, India, the Chiari looks different to me, and here it looks different. In Journal of Neurosurgery, it is written that the Western population is different, Indian population is different. I'm saying human being is the same, whether it is in India or in Morocco or is in China. In China, there are many people who are my followers. China is just don't relax. Just relax and enjoy. Don't. Now the listen is, now my next, now he says, my friend is saying OPLL. So you wait for the coffee, and my next lecture is on OPLL. And then you have to say yes or no, okay? No, let me complete. So in Journal of Neurosurgery, it was written that it works in maybe people who have craniovertebral bone anomalies. Then I had written one more article about patients where there were no bone anomalies. As I said, this father can have many children. Basilar invagination with Chiari, or basilar invagination without Chiari, or only Chiari, or only syrinx. So Chiari is one of the children of this father. Whether the father has 2 children or 3 children does not matter. Father remains father. Other thing is, you know what? In children, if you have a child, sleep apnea is one of the most prominent symptoms in children. Voice disturbance, breathing disturbance, tiredness during playing, most important symptoms in children with Chiari malformation. You see your patient. Instability is more pronounced in children. C1, C2 fixation is more difficult in children with Chiari and syrinx. The results are more dramatic in children. So I leave at that. And one Mohammed is saying one more last difficult question. My, poor man from India.
What I would like to say that I'm very glad and thankful to having you in person with us, which is quite an enjoying time. All of us have read your papers and have heard your talks during many meetings. But I think that we have to think about your idea. Since all of us have practiced the compression for many Chiaris, but some of them, or I don't have the exact percentage, some of them didn't improve postoperatively. Then we can raise the question, why? But what is controversial, what is some confusion, that some proportion of that of the Chiaris improve really after the compression. This is the confused matter of that question. is chiari formation or chiari malformation. But what I can ensure all the colleagues that your concept is a revolutionary concept in craniovertebral junction, that we have enjoyed a lot the 3 cases we have performed together, and that push us to think at least first about this theory and try to learn it, and why not to perform it and see our personal experience about that. Thank you.
Merci, professeur Benzekmout. Alors moi, j'ai une question pour professeur Aït Ben Ali, et je pense que ça rejoint un petit peu les mêmes idées qui ont été déjà citées. On sait très bien que dans la chirurgie de la malformation d'Arnold Chiari, grosso modo dans la littérature, vous avez 50%, on aura une très bonne évolution. Grosso modo, on aura 30% de stabilisation, c'est-à-dire qu'il n'y aura pas d'aggravation, et à peu près 20% vont continuer à s'aggraver. Moi, je me poserais la question, est-ce qu'il y a des critères, en se basant un petit peu sur votre longue expérience, où vous pouvez dire, par exemple, que ce patient risque de s'aggraver, ou ça ne va pas s'améliorer, ou là, on aurait une bonne évolution, que ce soit des critères cliniques, radiologiques, ou même sur le plan anatomique, ce que vous découvrez au cours de l'intervention, par exemple, si vous trouvez qu'il y a une arachnoïdie très importante. Ma deuxième question, même question, c'est professeur Aldi, vous pouvez répondre, je pense tous les deux. Et ma deuxième question pour l'Arnold Chiari grade 0. Donc, qu'est-ce que vous faites? Vous faites la décompression osseuse, même s'il n'y a pas d'anomalie. Vous posez une valve, parce que c'est juste un problème d'hydrodynamique du LCR. Donc, qu'est-ce que vous proposez à ces patients? Parce que c'est là où il y a le problème. Vous avez une syringomie très importante, mais vous n'avez pas d'anomalie osseuse. Merci.
Bah, effectivement, la plupart des patients à qui on fait des décompressions stridurales, comme tu viens de le dire, ils ne s'améliorent pas tout le temps. Hein. Et je suis un petit peu gêné même durant mon exposé, et j'ai un peu gêné après l'exposé du professeur Gaoul. I think that we have to trust Professor Gaoul. I'm personally convinced by his philosophy, and I think we have to learn this technique and to switch, I think, progressively to Gaoul's techniques. Les patients ne s'améliorent pas beaucoup. Je pense qu'on doit apprendre ces techniques dans un premier temps, quitte à changer par la suite notre façon de faire, parce qu'effectivement, les patients avec syringomyélie ne s'améliorent pas tout le temps. Ils peuvent s'améliorer légèrement ou, du moins, on peut les voir un peu se stabiliser. Pour les Chiari 0, c'est des questions difficiles. On voit de temps en temps, c'est rare, mais on voit de temps en temps ces dossiers. On continue à faire des décompressions. Au lieu de le surveiller comme ça sans rien faire, on fait quand même des décompressions. Et ce qui ressort dans la littérature, c'est les décompressions avec arachnoïdolyse, parce qu'ils pensent qu'il y a un problème d'arachnoïde au niveau de la charnière. Mais ça reste une question difficile. Moi, personnellement, je suis un peu convaincu par ce que vient de dire professeur Gaoul. Et d'ailleurs, on l'a invité, on espère le recevoir prochainement dans notre université pour opérer des malades ensemble. Et voilà. Merci.
Moi, j'ai une petite question pour professeur Fikri. Alors, concernant la place de l'IRM de flux dans le suivi de ces malades opérés pour les malformations de la charnière cervico-occipitale, sur le plan technique, quand vous faites l'IRM de flux, est-ce que vous faites une évaluation comme ça visuelle ou vous faites la mesure carrément de flux? Si c'est le cas, où est-ce que vous mesurez le flux? Est-ce qu'il y a des valeurs seuil que vous jugez qu'il faut qu'on ait des valeurs supérieures pour dire qu'il y a une bonne amélioration?
Non, on fait une évaluation visuelle. Je pense que c'est vraiment suffisant.
L'artefact de flux.
Là, on voit le flux, voilà, on voit le flux passer.
D'accord. Et la place, est-ce qu'il y a des demandes dans ce sens, des demandes d'IRM de flux?
Ça commence. En tout cas, on commence à voir pas mal pour les hydrocéphalies, pour les malformations de la charnière, oui. Il y a une sensibilisation en fait, qui a été faite auprès des neurochirurgiens qui commencent vraiment à demander des IRM de flux de plus en plus.
D'accord, merci.
Très bien, donc je remercie les différents orateurs pour cette première séance. J'invite...
Une autre question, après le
Une
professeur
autre question.
Michel.
Allez-y, monsieur.
Thank you very much, Professor Atul. It's very pleasure to see you in Morocco. You are illustrated that all the malformation of craniovertebral junction is the concept of Atlantoaxial instability. So, what I would ask for a radiologist in order to demonstrate this concept, in order to guide me in chirurgy.
Please.
What I would ask for a radiologist in order to demonstrate this concept and guide me for my technique, my surgery technique.
So you know what I do nowadays? I used to do is lateral imaging, lateral, sagittal, CT scan of the facets. So I showed you there can be listhesis, there can be retrolisthesis of the facet. When the atlantodent, see the only parameter in the literature to show instability is atlantodental interval increase. There is no other parameter. Atlantodental interval increase. And compression of the dura and neural structures. These are the parameters. But you see the facets. Nobody has talked about facets. You do lateral imaging and see the facets. So I divided instability into 3 groups. Type A is listhesis, type B is retrolisthesis, and type C is they are in alignment. So 3 groups. More recently, I have started doing dynamic rotatory imaging. This is one article which is also published in, you please read. I do now CT scan in supine. One is neutral position, one is flexion, extension, one is right lateral, right tilt, left tilt. So I am doing these kind of imaging. But these imaging are just more of a, academic exercise. But when I see Chiari, for me, whatever they say, show or they don't show, instability is the issue. But I have got some beautiful results on my rotatory imaging, which are going to be published very soon. You please read them. What happens when you do lateral tilt? What happens when you do rotatory? When there is no compression by the bones, no compression anywhere, what happens in the rotatory imaging?
Thank you. Merci à tout le monde. Donc, c'est la pause café. Nous allons, juste après, on a une pause café de 20 minutes. C'est à gauche et puis on reprend à droite.
On va le vérifier tout de suite.
قطع المايك. قطع المايك. Très bien. D'accord. Donc, bonjour chers maîtres. Nous allons reprendre donc cette deuxième session. J'appelle les différents modérateurs, donc professeur Chaoui, professeur Maqidi, professeur Amrani et professeur Moufid à prendre leur place. Je vous remercie pour ça. Donc cette deuxième session va débuter donc avec professeur Aldea. Donc monsieur le professeur Sori. Si vous allez commencer, c'est ça. Professeur Sori Aldea donc, est un neurochirurgien spécialisé dans le traitement endoscopique et microchirurgical des tumeurs de la base du crâne et de l'hypophyse, des tumeurs des ventricules cérébraux ainsi que de la pathologie vasculaire cérébrale et médulaire. Donc il a participé à de nombreux cours et stages de formation dans des domaines aux États-Unis, en Allemagne et en Suisse. Et donc il est auteur et co-auteur de 33 articles scientifiques et de 2 traités de spécialité. Il est bien évidemment membre de l'INFE, c'est la Fédération internationale de neuroendoscopie. Il s'intéresse essentiellement donc aux techniques mini-invasives dédiées aux tumeurs de la base du crâne. Et il a mis une chaîne donc, sur les techniques microchirurgicales et endoscopiques en neurochirurgie. Donc je vous remercie, M. Aldea, d'être présent avec nous, comme souvent.
C'est bon, je vais le lancer. Je peux lancer la key. Je peux lancer c'est un Mac, donc ça va marcher. Ouais. En fait, on ne la voit pas sur l'écran. Ah non, c'est pas celle-là, excusez-moi. C'est extrême latéral. Pardon. On n'est toujours pas. La vidéo marche, mais on n'est pas sur l'écran. Bonjour et merci beaucoup pour cette invitation. C'était déjà une première session extrêmement intéressante et c'est assez difficile de continuer après des topos si intéressants, notamment celui d'une légende de la neurochirurgie, le professeur Goel. Si vous me permettez, je vais faire ma présentation en anglais par respect pour le professeur Goel. Donc I will speak about the extreme lateral approach of the craniovertebral junction, some tips and tricks. But first of all, I should mention that I have the chance to work in a multidisciplinary team, which involves several of my colleagues, ENT surgeons, orbitopalpebral surgeons, neuroradiologists, neuro-ophthalmologists, internal medicine, and also external collaborations for radiotherapy, proton therapy, and stereotactic radiosurgery. So the topics I will talk about, it's the selection of the approach in CVG pathologies, the definition of the extreme lateral approach, it's not so obvious, its indications, and some tips and tricks and a video presentation. So you're all familiar with this famous picture of the Roton textbook, and you know that there are plenty of approaches. What we say usually in medicine that when you have a lot of approaches, anyone is perfect. So you need at least to be familiar with some of them. But before, let's think how we choose our approach. And I think there are several questions we should ask. And the first question is, where is the lesion? Is it anterior, anterolateral, posterolateral, or posterior? And also, what type of lesion are we dealing with? Is it a tumor, a malformation? Is it a vascular lesion, inflammatory, infectious? And finally, is it intradural or extradural? So basically you have 4 options. Of course, the anterior approaches, the endoscopic, endonasal, and the transoral approaches, the posterior, the extreme lateral or anterolateral in the French terminology, and the far lateral or the posterolateral in the French terminology also. So let's see a little bit how do you choose. For instance, for posterior intradural or extradural pathology is quite obvious. We'll choose a simple posterior approach everyone is familiar with. For anterior or anterolateral intradural pathology, the far lateral approach works very well, but in some selected cases, the anterior approaches may be interesting. When I'm speaking about far lateral, I must mention, at least in my experience, I never do partial condylectomy for intradural lesions. I don't think that is needed. You have enough exposure if you expose the foramen magnum up to its lateral limit. I think it might be needed if you operate on very small lesions. And in this case, you should wonder if you really should operate them. For lateral and for the extradural pathology, for the lateral and anterolateral extradural pathology, this is the indication of the extreme lateral approach. And for anterior extradural pathology, we use mainly anterior approaches, but also some the extreme lateral approach can be useful. And finally, something which is usually forgotten, follow-up is an excellent approach in many cases. So what is the extreme lateral approach? This is a very confusing term because if you look in the literature, the term was coined by Professor Shekhar and Professor Sen in the 90s, but it's difficult to say if it's a variant of the far lateral approach or if it's a completely different approach. And the problem is terminology, but also ego, because practically in the same time, Professor Bernard Georges describes the anterolateral approach, which is quite similar, it's just the direction which is different. And Professor Fukushima describes the elite approach, which stands for extreme lateral, infrajugular, transcondylar, transtubercular approach. And also because you have variants of this approach, which are practically similar. For instance, if you look in the literature, the far lateral juxtacondylar approach is exactly the same as the extreme lateral retrocondylar approach. So the definition is not obvious, but if you have to stay simple, it's a true lateral approach to the foramen magnum, which gives you access to anterolateral lesions and is centered on the V3 segment of the vertebral artery. And the second point would be that you dissect usually the muscles, the suboccipital muscles, posteriorly, not anteriorly. Well, in this seminal paper of Professor Shekhar, he described several variants of this approach. The transfacetal, which is used for upper spine lesions, and which implies a partial removal of the C1, C2 facet joints and of the occipital condyle. The retrocondylar I just spoke about, it's practically the far lateral without condylar drilling. The partial transcondylar, which drills the posterior third of the condyle and transpose medially the vertebral artery. The complete transcondylar, which gives you access to the odontoid and the lower clivus, but obviously you need afterwards to do a fusion. The transjugular, which involves a complete mastoidectomy and an anterior transposition of the seventh cranial nerve. And finally, the transtubercular, which is a transjugular with an added removal of the jugular tubercle. So let's see in the images what does it mean. First approach is this is a transfacetal. So you drill the lateral part of the posterior arch and you give access, and you have access to the anterior part of the spine. The retrocondylar, which I told you, for me, it's practically the far lateral, very little difference with the far lateral. The partial transcondylar, when you drill, but you drill less than 50% of the condyle, there are a lot of discussions about the stability of the CV junction after the drilling of the condyle, but 50% it's like the minimum, which is accepted to consider that the craniovertebral junction is still stable. The complete transcondylar, this is for clivus and odontoid lesions, where obviously you need fusion. The transjugular, which is the ideal approach for foramen jugular paraganglioma and schwannoma. And finally, the transtubercular, which is practically disappeared because it was described mainly for vertebral basilar junction aneurysm, which are not so much surgical anymore. Well, let's see the indication of the extreme lateral approach. Actually, the landscape was modified a lot by the apparition of endoscopy, the development of the radiosurgery, by the endovascular techniques. The vertebral basilar junction aneurysm are no longer surgical. We don't operate this kind of lesion in France for at least 20 years. And also, the pendulum is swinging towards less invasive and less radical solutions. So which techniques are still needed? I think the retrocondylar or the far lateral approach is obviously still needed for anterior intradural lesions. The complete and partial transcondylar for extradural anterior lesions, and the transjugular for the foramen jugulare lesions, paraganglioma or schwannoma. And we go to the tips and tricks. I try to get back some time. So positioning and incision, there are several variants described in the literature. It can be done in the lateral or supine position. In my experience, almost all cases I did, they needed occipitocervical fusion. So I think the prone position might be interesting if you need to fix the patient. You have to keep the head neutral because in this position you might get confused about the position of the vertebral artery. You have several types of incisions that have been described, either an inverted L, a C, or a hockey stick incision. And finally, you need to know the 3 or 4 muscular layers. It depends if you consider there is only 1 or 2 intermediate layers. And basically, the surgery starts with a suboccipital craniectomy and a C1 hemilaminectomy. The difficult part starts when you get around the vertebral artery. So there are some fundamental principles you have to respect. What I teach my residents, it's for all approaches, once you are 1 centimeter, 1.5 centimeters away from the midline, you should throw away your monopolar coagulation. Neuronavigation, don't counter it. You have to think that your MRI was acquired in supine position and you don't operate your patient in supine position, but Doppler might be reliable if you don't stretch your retractors too much. Otherwise, if you stretch your retractors too much, you don't have any signal on the Doppler, so it may be misleading too. Your best friend, as my mentor, Professor George, said, is the periosteum. And people are usually afraid about the venous plexus bleeding. Actually, it's something that is manageable. You can pack it, but it's even better if you coagulate it. And you have to be aware that there are branches from this segment of the vertebral artery. You have meningeal and muscular branches, which are constant. But you also have the pica, which may arise. In the literature, they say that it may go up to 20% of the cases. I think it's largely overestimated. And this is a variant. This is a variant which was described by Professor George. And what is different in this variant, it's already the positioning. The patient is supine with the head slightly turned, with an incision which follows the anterior border of the sternocleidomastoid muscle. All the muscles are reflected posteriorly. You identify the 11th cranial nerve, and afterwards you can expose the suboccipital triangle, the vertebral artery, both above and below the C1 vertebra. Let's see some cases. The first case, it's a 60-year-old female patient without past medical history. She came for repeated attacks of torticollis, a falling head sensation, and a progressive right hypoglossal nerve palsy. She had on the CT scan very large osteolytic lesions of the right occipital condyle. On the angio-CT scan, there were slight enhancements in the posterior area, which corresponded on the MRI, and the lesion was mainly hyper T2. So we were quite confused about this lesion. We did an angiography which showed a very late blush at the level of the lesion, but no real hypervascularization. So we operated her in a prone position with a hockey stick incision, a small suboccipital craniectomy and C1 hemilaminectomy, dissecting and freeing the vertebral artery at the C1 foramen transversarium, inforomedial transposition of the artery, and resection of the lesion, which showed to be a nauseous venous malformation, and an occipitocervical fixation with a very, very good postoperative result. And to end, let's see if it works, a video about the extreme lateral approach and occipital cervical junction. This is a patient, 50 years old patient, who had been operated at 15 years old of a chordoma by a lateral approach and had radiotherapy. And she was followed by my otological partners for repeated osteoradionecrosis of the external auditory canal, as you can see on the right side. There is extensive osteoradionecrosis. There was no recurrence for 35 years till she came with the swallowing disturbances and bilateral hypoglossal palsy. So the video starts here. The occipital bone is here, the C1 posterior arch, the vertebral artery sulcus. And what I told you, once I get to the vertebral artery groove, I don't use Bovie anymore. It's only bipolar and scissors. You can see this is a coagulation of the perivertebral venous plexus, so you can perfectly skeletonize the artery. It's important to check from time to time the permeability to be sure that your retractors do not stretch. And afterwards, once you dissected the artery, you can remove the bone, which is underneath. Some people will drill. I prefer very fine bone rongeurs. I think it's easier to control. And then you identify the C1 foramen transversarium, and you do what I call a C1 foramenotomy. So you freeze the artery from the foramen, because your objective is to get to the condyle, which is hidden beneath the V3 segment of the vertebral artery. Sorry, I stopped the video. So we continue the foraminotomy. Of course, you have vertebral venous plexus at that level also, but it's quite easily controlled by coagulation. It's important to do as wide as possible opening of the C1. Like this, you can dissect the artery. As the patient had radiotherapy, there were quite strong adhesions, some fibrosis, which was unusual. So we need to use a sharp dissection to dissect the artery from the underneath structures. And now you see you can move the artery, extend the opening of the C1 foramina. And now you can push it downwards, and you have a very good access to the occipital condyle. The rest, it's as usual. We drill what is left from the cortical bone, and you have full access to the occipital condyle. Well, chordoma, it's like usual. When they are soft and suckable, you are a very good surgeon. When they are firm and hemorrhagic, you're not so happy with yourself. This one had different sectors, some soft and suckable, some firm. And this is the extension of the resection of the condyle. We expose a little bit of the dura of the posterior fossa to increase the exposure. And this is the resection of the medial part of the condyle. As you can see, the cavity is bleeding constantly. And these are some rests of fibrosis, which are sharply removed. And now we identify the hypoglossal canal, the hypoglossal nerve passing through the nerve. She had already a hypoglossal palsy, but we decided to preserve the nerve. And we continued the surgery until we reached the anterior part. And progressively, we identified the C0-C1 joint, extended the resection in order to improve the access to the tumor. And this is the dissection of the tumor from the medial part of the foramen magnum. There is a small CSF leak. As you can imagine, there was quite a lot of fibrosis as she was already operated and irradiated. And I think this is the final part, hemostasis, which needed bipolar, but also some fibrin gel. And afterwards, we did the same thing on the other side and did an occipitocervical fusion. We repaired the small CSF leak with a fibrin sealant. And I think that's all. Thank you very much.
Merci, professeur Aldea, pour cette belle présentation. On laissera les questions pour la fin, si vous voulez bien. Maintenant, on donne la parole à mon ami, le professeur Louhabi, qui va parler de la chirurgie du foramen magnum, des tumeurs du foramen magnum.
Merci, Monsieur le Président de la session. I would like to thank once again Professor Atul Gul for accepting to come to Morocco and to share with us his huge experience. I made my presentation, my slides in English, so I will speak in French, so for the young, but I made my slides in English on purpose. Ça ne passe pas. Okay. So, nous avons, c'est bon. Nous avons assisté à une très bonne discussion concernant donc l'anatomie de cette région. Je vais passer rapidement. Zone très difficile, complexe. La chirurgie est compliquée. Les risques chirurgicaux sont importants. Il y a plusieurs voies d'abord et il faut choisir justement la voie d'abord idéale pour le patient idéal. On a eu donc une amélioration donc les 2 décennies donc de la pronostic et particulièrement de la mortalité et la morbidité grâce à l'utilisation entre autres de l'endoscopie, surtout le développement donc de l'imagerie. Alors la complexité de cette région a été bien exposée par le professeur Benzarmout, mais juste pour vous rappeler le nombre donc de structures qu'on peut voir et qui vont donner naissance à un grand nombre de tumeurs. Différents types de tumeurs, extraaxiales, intraaxiales, primitives, secondaires, et on va surtout insister sur 3 types de tumeurs qui sont des tumeurs considérées comme tumeurs bénignes, particulièrement les méningiomes et les schwannomes, et les chordomes qui sont des tumeurs à bénignité histologique, mais sont considérées comme des tumeurs malignes. Alors, plusieurs voies d'abord, comme vous le voyez, pour arriver à cette zone qui est très profonde, difficile d'accès, voie antérieure, voie postérieure latérale, voie transcervicale. C'est un petit peu ce qu'on voit dans la littérature, c'est des voies classiques qui ont été utilisées. Et on va se rendre compte qu'avec le temps, ces voies vont se limiter à des voies plus ou moins liées à chaque type de tumeur. Alors, quelle voie d'abord choisir? Le choix de la voie d'abord va dépendre bien sûr de la localisation de la tumeur, une tumeur intradurale versus une tumeur extradurale, une tumeur antérieure par rapport donc au foramen magnum versus postérieur, la taille de la tumeur. Il y a des tumeurs qu'on ne peut pas aborder juste par une seule voie, mais par plusieurs voies, et le type de tumeur. Le traitement d'un chordome, ce n'est pas celui d'un chondrosarcome, ce n'est pas celui d'une métastase, non plus ce n'est pas celui d'un méningiome. Alors, les voies d'abord donc antérieures ont été proposées essentiellement pour les lésions extradurales. Et parmi ces voies, on peut avoir donc la voie transorale, la voie transphénoïdale, la voie transcervicale extrapharyngienne donc supérieure, la voie postérieure particulièrement pour les lésions intradurales et particulièrement donc la voie postérolatérale avec ou sans résection donc du condyle. Mais en pratique, plusieurs voies sont combinées pour parfois arriver à faire une exérèse complète. Comme vous le savez, ces tumeurs sont des tumeurs bénignes et donc l'exérèse complète peut garantir une survie à long terme. Alors voilà un petit peu la série que je veux partager avec vous. Donc nous avons opéré sur les 25 dernières années 106 cas donc, de tumeurs du foramen magnum. Et la répartition, comme vous le voyez, on a eu 55 cas donc, de méningiome, cordon 27, les schwannomes 14 et puis d'autres types de tumeurs. La majorité de ces tumeurs étaient localisées au niveau de la région antérieure ou antérolatérale, comme vous le voyez, et donc ça pose un problème énorme donc de prise en charge. D'ailleurs, j'ai exclu donc de cette présentation les méningiomes postérieurs. D'abord, ils sont très rares et puis ils ne posent pas vraiment de problème pour la chirurgie. La pathologie donc de cette région va entraîner un certain nombre de manifestations cliniques, comme vous le voyez, très très variables, très d'un patient à l'autre. Mais ce qui est important, c'est que la majorité des patients se présentent chez nous avec déjà donc un déficit moteur et avec donc des paralysies des nerfs crâniens. Et comme vous le voyez, il y a d'autres donc signes qu'on peut voir. C'est des malades souvent très handicapés pour lesquels la chirurgie risque d'être lourde et donc un post-opératoire. Il faut prévoir un post-opératoire assez long et une kinésithérapie donc également assez longue. Alors le premier groupe que je vais partager avec vous, c'est le groupe des méningiomes. Les méningiomes sont les tumeurs donc les plus fréquentes au niveau du foramen magnum. Et ils représentent à peu près 1 à 3% de toutes les tumeurs intracrâniennes. Et souvent, comme j'ai dit, la majorité de ces méningiomes de la charnière sont localisés au niveau de la partie antérolatérale. La chirurgie est un challenge, et surtout dans cette localisation, c'est pour cela qu'il y a plusieurs voies d'abord qui ont été proposées. Alors, ces voies d'abord sont proposées suite à des classifications. Dans la plus ancienne, c'est celle donc, de Cushing Eisenhardt. C'est une classification très simple, méningiome crânio-spinaux ou spinocrânien. En fait, il n'a pas beaucoup d'intérêt. Cette classification est beaucoup plus intéressante parce qu'il classe les méningiomes en fonction de leur situation par rapport au ligament dentelé, en avant du ligament dentelé ou en arrière du ligament dentelé, et avec justement les déplacements donc, des structures donc, vasculaires et nerveuses. Il est clair que les tumeurs qui se développent en arrière du développement dentelé vont pousser un peu la région donc, bulbaire en avant, et le chirurgie sera plus facile, alors que si au contraire on a un méningiome de la partie antérieure ou antérolatérale, la situation est un peu plus difficile. Alors, toujours, donc, il y a eu une nouvelle classification de foramen de magnum par Bruno, qui, en plus de la localisation antérieure, antérolatérale, intra- ou extradurale, il ajoute un petit peu la localisation par rapport à l'artère vertébrale. Et puis une troisième classification un peu plus récente qui, en plus, essaie justement de prédire la compression et le déplacement des structures vasculo-nerveuses avant la chirurgie. Et ceci est très important. Si ces structures sont déplacées en avant, c'est-à-dire que la tumeur elle est postérieure, la chirurgie est moins risquée que si la tumeur est antérieure et tous ces éléments sont déplacés donc vers nous, avec un type 4 où il y a donc une atteinte importante donc avec un envahissement et des nerfs et des artères, l'artère vertébrale qui sont dans la tumeur. Alors voilà un petit peu la localisation dans la littérature. La majorité des tumeurs, comme j'ai dit, elles sont antérieures ou antérolatérales. Dans notre série, nous n'avons eu que des tumeurs antérieures ou antérolatérales, pas de tumeurs postérieures de méningiome. Voilà les voies d'abord proposées, soit la voie d'abord conventionnelle médiane sous-occipitale ou la voie d'abord postérolatérale proche. D'emblée, je vous dis, dans notre expérience, nous avons préféré opérer tous les malades par la voie postérolatérale et je vous explique pourquoi. Alors, sur cette série, donc, opérée par voie postérolatérale, il y a plusieurs avantages de cette voie postérolatérale. D'abord, c'est une voie qui est familiale à plusieurs donc, neurochirurgiens. Elle permet une ouverture assez large avec un accès justement sur la région recherchée, avec un risque minime donc, de fissure de LCR. Et on peut, au cours de la même chirurgie, réaliser une instrumentation postérieure. Il y a certains donc, inconvénients, c'est surtout lorsque la tumeur est très antérieure, on peut avoir l'interposition justement de la région bulbo-médulaire. Alors, donc, rapidement, sur la position, on peut avoir soit une position donc, prone, donc ventrale, ou une position semi-sitting position, sachant que la semi-sitting position peut parfois entraîner des petits problèmes donc, au niveau de l'embolie, avec risque d'embolie, mais il a des avantages. Et procédure chirurgicale, après ouverture de la durmère, on fait à ce moment-là donc une résection donc du ligament dentelé. La tumeur est débulquée, puis on arrive à l'enlever à la fin. Voilà quelques cas illustratifs. Donc c'est une patiente qui se présente avec donc une nucalgie, avec une hémiparésie. Alors après ouverture donc de la durmère, on réalise une section des ligaments dentelés qui permet justement d'avoir accès à la lésion sans trop comprimer la moelle cervicale. La tumeur va être débulking. On peut utiliser le ultrason, l'aspirateur ultrason, mais également parfois la tumeur est fibreuse et on doit la fragmenter, comme on le fait ici, au ciseau, sans faire de traction importante sur la moelle. Et on arrive donc à faire une exérèse complète de ces tumeurs. Voilà, avec, on voit ici C2, et donc le temps de fermeture. Voilà, donc le deuxième cas qu'on présente ici, c'est un patient donc, de 45 ans qui a été opéré pour un méningiome donc, à localisation, comme vous le voyez ici, antérieure, avec résection complète post-opératoire, évolution favorable, sans résection du condyle. Deuxième cas qu'on a opéré, c'est une collègue qui est venue pour une tumeur, donc justement, comme vous le voyez, un méningiome qui est antérolatéral, qui a été opéré. Et on voit ici, cette diapo juste pour vous montrer un peu qu'à la fin, on va avoir une bonne visibilité et un peu, donc voilà la lésion. La lésion est un peu aspirable. On arrive à, là, on résèque sa base d'insertion sur la durmère. Donc c'est la même technique. On essaie de garder ce plan arachnoïdien qui protège donc la moelle cervicale et le bulbe. Et puis, une fois la lésion est enlevée, on arrive à voir à ce moment-là le contact qu'il y avait avec l'artère vertébrale et ces deux qui passent. Donc, cette voie permet justement l'accès sur l'artère vertébrale par voie postérolatérale sans résection du condyle. Alors, toute une discussion qui a été entre les deux voies sous-occipitale, postérolatérale ou transcondylienne. Lorsqu'on a comparé un peu la série, donc on a avec la série de la littérature, on voit que les deux voies permettent une exérèse complète plus ou moins similaire, avec quand même une différence au niveau surtout donc, de la morbidité. Il y a un peu plus de morbidité pour la voie transcondylaire à cause justement donc, du problème d'instabilité et de la nécessité d'instrumentation dans la majorité des malades. Et puis, pour nous, la voie postérolatérale sans résection du condyle est une voie qui est pratiquement qui permet un accès sur la majorité donc, de ces tumeurs sans problème. Et la question, est-ce que la résection du condyle est nécessaire? Non, elle n'est pas nécessaire parce que souvent ces méningiomes considérés comme des méningiomes trop antérieurs sont souvent des méningiomes antérolatéraux et que la majorité des tumeurs vont pointer latéralement et on peut avoir à ce moment-là un corridor qui permet justement d'accéder sur ces tumeurs et de largeur de tumeur, plus la tumeur est large, plus il est possible donc de l'enlever complètement. Donc la résection du condyle pour nous n'est pas nécessaire et voilà donc sur un préopératoire on peut envisager donc et prédire un peu l'endroit, le corridor pour enlever ces tumeurs. Alors le deuxième groupe de patients ce sont les cordons. Donc c'est 7 minutes qui restent. On va essayer justement de focaliser sur ce deuxième groupe de tumeurs qui pose pas mal de problèmes parce que comme j'ai dit c'est des tumeurs bénignes histologiquement mais sont très malignes sur le plan du comportement avec des extensions un petit peu antérieures, latérales, postérieures. Et malgré la résection complète, on peut avoir des récidives, malgré l'utilisation du proton beam thérapie. Donc, c'est une tumeur qui pose encore des problèmes. Alors, bon, quels sont les cas qu'on a? Ce sont des lésions qu'on a opérées au niveau du clivus inférieur et de la charnière cervico-occipitale. Alors, plusieurs voies d'abord. Nous avons utilisé la voie transorale chez 7 patients. Nous avons utilisé la voie cervicale antérieure chez 2 patients. La voie endoscopique, 14 patients, et la voie postérieure en postérolatérale en 2 cas. Alors, souvent, on utilise des voies combinées, antérieure et latérale, pour certains malades pour lesquels l'exérèse complète n'est pas nécessaire, n'est pas suffisante et n'est pas assurée par une seule voie. Alors, voilà les voies qu'on a utilisées justement dans la série. Alors, la voie transorale, bon, elle permet l'accès sur la partie inférieure du clivus, de l'atlas, et avec un champ quand même assez large, mais là quand même des complications, notamment c'est le problème donc de la fissure du LCR, le problème de l'infection et le problème donc de la cicatrisation au niveau de l'incision pharyngée. Alors voilà, bon, on a vu ça sur l'anatomie, voilà ce que donne la voie transorale sur le plan anatomie donc cadavérique. Et voilà un peu donc, la voie transorale. Alors, depuis 2000 à 2015, on a utilisé cette voie chez 7 patients. Bon, une fois, on incise la muqueuse pharyngée. Ça, c'est sous microscope. Une fois la muqueuse pharyngée est incisée, on va découvrir donc la tumeur. Souvent, si on a la chance de trouver une tumeur qui est aspirable, ça se passe bien. Mais parfois, on a obligé donc justement donc d'essayer donc de réséquer par morcellement, par fraisage, des structures osseuses qui sont infiltrées par la tumeur. Tout ça, c'est de la tumeur. Alors, c'est une voie qui reste sur le plan médian assez intéressante, mais limitée latéralement. Bon, déjà, on est sur la dure mère ici, donc ce qui reste de la tumeur, donc l'exérèse est considérée assez large dans ce cas particulier, et on peut assurer une exérèse pratiquement complète. Alors, quelques résultats. Voilà un patient qui a été opéré. Voilà un patient qui a été opéré, 34 ans, pour un cordome de la jonction cervico-occipitale, préopératoire et post-opératoire après un abord transoral, exécution complète. Mais ce n'est pas toujours le cas. Ça, c'est le cas d'un, comme vous le voyez, il est énorme, infiltrant. Bon, on l'a opéré par voie transorale avec une résection considérée comme subtotale parce qu'il encore persiste un peu de la tumeur latéralement, adressée pour la radiothérapie. Alors, on peut également utiliser la voie postérolatérale dans le cas particulier de ce cordon qui était plutôt donc, à orientation postérieure et avec une exérèse pratiquement totale par la voie postérolatérale. Ça, c'est le post-opératoire, le préopératoire par la voie postérolatérale. Souvent, il faut faire des voies combinées, comme c'est le cas de ce patient. On commence par une voie postérolatérale pour cette lésion, pour essayer d'enlever tout ça. Et puis, dans la deuxième chirurgie, une voie transcervicale antérieure pour enlever cette partie antérieure. Ça, c'est après la première chirurgie, il reste cette partie antérieure. Puis, on fait la deuxième chirurgie et voilà donc le contrôle post-opératoire définitif. Donc, souvent, dans le cordon, il faut voir plusieurs voies d'abord. Alors, la voie endoscopique, nous l'avons pratiquée chez 14 malades les 10 dernières années. Il a beaucoup d'avantages par rapport à la voie transorale microchirurgicale, si vous voulez, particulièrement le fait qu'il y a moins de traumatisme de la région pharyngée, mais elle a quand même ses limites, notamment l'accès sur la partie inférieure à C1 et latéralement, et au niveau justement donc, du jugulaire foramen. Alors, ça, c'est un certain donc, de dossiers d'un patient jusqu'à illustratif. Vous le voyez ici, c'est un patient qui se présente avec un cordon donc, de la région clivale qui va au niveau donc, du tronc occipital. Bon, après avoir relevé un lombo nasoseptal pour la fermeture, donc on est déjà donc au niveau, on arrive à voir le clivus et le processus, elle est là, voilà, il est là. Bon, dans ce cas particulier, donc il est pratiquement dans l'axe. L'endoscopie a l'avantage de pouvoir voir donc un petit peu dans les angles, donc l'illuminisation est meilleure par rapport à la voie classique chirurgicale transorale. Donc on aborde la tumeur, débulking, inspiration, on voit que la tumeur se développe en intradural. On arrive à enlever ce dernier bourgeon donc, de la tumeur. Voilà, et le temps valtron basilaire avec donc ces structures. Donc, et puis, il y a encore un peu de tumeur latéralement. Et puis, il faut assurer la fermeture. Ça, c'est un petit peu les inconvénients de ces voies endoscopiques. C'est le problème de la fistule du LCR. Donc, il faut vraiment bien assurer une fermeture pour éviter justement le problème donc, de fistule du LCR, de la méningite. Voilà, donc là, on est à la temps final avec une exérèse complète dans ce cas particulier. Bon, il faut assurer une bonne fermeture avec par suite de la graisse et de la colle. Donc, alors, ce malade donc, a été opéré également pour un cordome. C'est juste pour vous montrer que parfois cette ouverture de la dure-mère n'est pas toujours aussi importante. Une fois on enlève donc la tumeur, vous allez voir que une fois la tumeur est enlevée, voilà la petite ouverture de la dure-mère qu'on arrive à... Voilà, il y a un peu de... Voilà, c'est une petite ouverture donc, qui est donc relativement facile à fermer par de la graisse et à la fin donc, de l'intervention. Alors, le dernier malade, le cordon qu'on a opéré, c'est ce malade, donc, patient donc, de 38 ans, patiente, donc un cordon de la jonction, donc craniovertébral. Toujours donc préparation donc de lombo-nasoseptal au départ. Et puis voilà. Il faut bien driller, bien réséquer la partie inférieure, donc pour arriver au niveau donc du clivus inférieur et au niveau donc de la partie supérieure donc du foramen magnum. L'exérèse est un peu hémorragique. Voilà, on commence à voir ici la dure-mère ici. Mais il faut continuer vers le bas parce que la tumeur s'étend jusqu'à pratiquement au niveau donc de l'apophyse odontoïde. Et puis, pour faire l'exérèse la plus large possible. Alors, quels sont les résultats de cette série de cordomes? Bon, l'exérèse totale a été assurée donc à peu près un malade sur deux. La mortalité est nulle, la morbidité quand même à peu près 23%. Surtout le problème donc de l'aggravation, enfin du fistule de LCR. L'évolution, alors la majorité des malades s'améliorent dans le post-opératoire immédiat et 4% s'aggravent. Alors, le problème des cordomes, c'est le problème de la récidive, pratiquement dans 40 à 50% des cas, malgré le traitement par la radiothérapie. Alors, il y a toute une discussion sur le problème donc, de la prise en charge sur les cordomes, avec beaucoup donc, de controverses sur cette point d'abord. Alors, le dernier groupe, rapidement, juste une diapo sur les schwannomes. Les schwannomes de la région donc, du foramen magnum, nous avons opéré 14 malades. Opérés tous par voie, la majorité par la voie postériolatérale, parfois par la voie antérieure, avec donc un résultat très favorable dans la majorité donc, des cas. C'est un cas qu'on a opéré récemment avec voie postériolatérale, exérèse complète donc, de la lésion. Donc en conclusion, c'est une zone complexe, c'est vrai, avec beaucoup de problèmes d'accès. Les méningiomes donc, de la région du foramen de magnum peuvent être opérés par la voie postériolatérale sans résection du condyle. Souvent, il y a un corridor. Dans les cordomes, la voie transorale peut être remplacée actuellement par la voie endoscopique, qui permet un meilleur jour sur la région, tout en sachant que cette exérèse doit être complétée par d'autres voies d'abord. Et la stabilisation du rachis doit être considérée, surtout dans les rachis instables, après résection du cordome. La mortalité et la morbidité sont encore élevées et surtout le problème des récidives dans le problème du cordome. Je vous remercie.
Merci professeur Ouhabi pour cette excellente présentation. Donc, il parlait du traitement de la prise en charge des tumeurs du foramen de magnum, qui était bien faite et illustrée par des cas cliniques, des vidéos très importantes. Maintenant, on va continuer avec professeur Goel qui va nous parler, il va continuer de nous parler. Donc, d'ailleurs, il nous a fait voyager dans la première partie de cette session. Donc nous parlons de l'instabilité et C1, C2. Donc toute pathologie au niveau de la charnière, elle est liée. Peut-être il faut chercher cette instabilité C1, C2, d'où l'intérêt de bien travailler avec nos chers collègues radiologues pour essayer de comprendre où est le problème dans cette charnière. Donc now let's to continue with Professor Goel to discuss about her new philosophy about this cervical cranial junction. Thank you.
Okay, my dear friends, fasten your seat belts. I'm going to introduce to you a beautiful new concept. Enjoy it, relax and enjoy. Looking beyond decompression, looking what images show. I'm introducing to you a concept. Compression is never primary. Compression is never an issue. Compression is secondary, it is protective, it is adaptive, and it indicates unstable spine, and you stabilize, compression goes, and decompression is never the treatment. So this is what I told you. Human body is different. We humans are different. We stand on two legs. No other animal stands on two legs. All our muscles are located here, all muscles. You put your finger, you can feel the odontoid process. You put your finger here, you can feel the cervical body. Here, the strong, all muscles are focused to make us stand like this. All muscles are focused on the facets, all muscles. Facets form the fulcrum of all spinal movements. For a horse, muscles are here. For a bird, muscles are here. From the human body, the muscles are here. When these muscles become weak, the facets become unstable. There is instability at the facet. That is the problem. If you don't do exercise, if you don't run, if you don't use your muscles, the facets become unstable. When these muscles become weak, there is instability at the facets. All the muscles are, the facets form the fulcrum of movement. You please read my articles on disc. Disc is divine, disc is never an issue. Disc is never a problem. Disc is the mother of spine. Mother can never go wrong, okay? So you just relax. I introduced to you a concept of vertical facetal instability. If you see your grandfather, he's shorter than you. Yes or no? Yes? He's shorter. Because there is a facetal instability, the facetal listhesis. Facetal instability is like telescope. Facetal instability is the point of genesis of spinal spondylotic disease. So I talked about instability at the craniovertebral junction, the problem in the muscles, the problem is at the facets, instability is the issue and stabilization is the treatment for Chiari malformation, for all those things which I have talked about earlier. So when the muscles become weak, the facetal instability is the problem, stabilization is the treatment. There is listhesis of one type, listhesis of the other type, and the listhesis of the third type. All these problems which instability creates look compressive. They look compressive. They look pathological. The whole world calls them pathology. The whole world calls them pathology. The whole world treats them by decompression. I am saying the pathology is secondary, it is protective, it is reversible. The problem is instability. You treat stabilization, the pathology will go. So this is what I have shown you in my previous lecture, and this is what I have shown you, that this pathology, assimilation of atlas, they are not pathologies, they are secondary, they are reversible, they are protective, and I have published several articles where we said transoral surgery, historical. Then I said foramen magnum decompression surgery, historical. Now today I introduce to you degenerative spine and subaxial spine. I must tell you that I have been doing anterior surgery for a long time. I have written several articles by anterior approach. This is in the book of Sweet and Smedek. This kind of decompression, removal of this, corpectomy, discoidectomy, this kind of implant has been my regular feature. I introduced this kind of screws, transdiscal screw, tricortical screw, and several other anterior surgery. Now look at this slide, please, particularly young people, look at this slide. Reduction in the joint space, buckling of this ligament, osteophyte formation. They are not primary issues. They are due to unstable spine, vertical instability. Osteophyte formation here, osteophyte formation here, osteophyte formation here. They are not primary problem. They are secondary to unstable spine. Decompression is not the treatment, stabilization is the treatment. Did you get what I said? Again I show you. Reduction in the joint space, buckling of the ligament are due to vertical instability. They are secondary. They are protective. They indicate unstable spine. They are reversible. So this was my article. For the first time in the literature, we said that instability is the issue in degenerative atlantoaxial joint and stabilization is the treatment. Do you know what is this? The whole world called it pseudotumor. And for several decades, this tumor was removed by transoral surgery, lateral approach, extreme lateral approach, and all those approaches. For the first time, we said that this pseudotumor is like an osteophyte. This indicates atlantoaxial instability. You don't have to remove this tumor. You don't have to remove this atlas. C1, C2 fixation is the treatment, and this will automatically disappear. Now, many people in the world follow this concept. So, atlantoaxial instability is the cause of retroodontoid pseudotumor, and stabilization is the treatment. This cyst, it is very easy to remove this cyst, but it is not necessary. You see unstable spine, you stabilize, this disappears. This is secondary, this is protective, this is reversible. This kind of pseudotumor, this kind of, in os odontoideum, it is atlantoaxial instability, this is secondary. This kind of bone is a kind of a buffer. This is secondary, this is protective. You don't have to remove this. You stabilize, this disappears. So you please read this article of mine in World Neurosurgery where I said retroodontoid pseudotumor, pannus, cyst, they are secondary and protective. Rheumatoid arthritis, pannus, the whole world was doing transoral surgery, whole world. Whole world was doing extreme lateral and posterior lateral and all kind of lateral surgery. For the first time in the literature, we said this buckling is due to vertical instability. You distract, you fuse, pannus disappears. So this was in Journal of Neurosurgery. Pannus disappears, and this is complete revolution in the treatment of pannus. So after that, there have been several other articles of mine in the literature which you can read. Basilar invagination, lot of craniovertebral junction problems are due to instability at C1, C2, I mentioned. Nobody in the world has talked about facetal instability, facetal listhesis. Nobody in the world. My dear friends, carefully look at this slide, carefully. Reduction in the intervertebral space, bulging of these ligaments, bulging of this disc, osteophyte formation is not a primary event. It is due to vertical facetal instability. Instability is the problem. These are secondary, these are protective, these are adaptive, and these are reversible. Osteophyte formation, all bone formation, this kind of bone formation is not a pathology. They are secondary to unstable spine. So about 20 years ago, we introduced this concept of disc herniation. We introduced facetal distractor spacers, and this was quite a popular technique. No decompression. You see this multi-level osteophytes and bulging disc, ligamentum flavum. We introduced these spacers as multiple levels. This is immediate post-op. You see everything is gone. Everything is gone. Complete revolution, no decompression. So this was published in Journal of Neurosurgery in 2011 with a cover page. Facetal distraction as treatment of single and multi-level cervical spondylotic myelopathy and radiculopathy. Same concept we introduced for lumbar canal stenosis and lumbar disc. This kind of lumbar canal stenosis, we introduced these spacers, and this was published in Journal of Neurosurgery in 2013. This kind of multi-level degeneration, we introduced these spacers without decompression. And these are my spacers, which are very heavily patented in America and in various countries. So essentially, decompression is the treatment for all spine surgeons in the world. Initially, I used distraction decompression, but then I changed. In 2013, I said even distraction is not necessary, only fixation for degenerative spine, only fixation. And then I produced this paper with more experience. You see please read the title of this article. Muscle weakness related instability is the cause of spinal degeneration, and spinal stabilization is the treatment. This is in World Neurosurgery. Now see this slide. Now here there is multi-segmental compression. What you will do? Tell me. You will either do laminoplasty or laminectomy or multi-segment this multi-segmental decompression or corpectomy. I have done only fixation, and after 18 months of surgery, everything has gone. And you have to only believe that this patient recovered remarkably in the evening of operation. You know, now you see this here, multi-segmental osteophyte, compression, this and that. What you will do? You will do decompression, multi-segment anterior, this or decompression. I do only fixation, and you see after 16 months of surgery, all the compression is disappeared. I have multiple patients like this, multiple. And I'm showing you some cases. You see this compression. This is after a few months of surgery. Osteophytes, bulging discs, they are secondary, they are protective, they are adaptive, they are reversible. I do this transarticular Camille's technique of fixation. Sometimes I do 5-level fixation in 10 minutes. Easy, strong, and solid. So this is multi-level here. No decompression, only fixation, and magic is the clinical result. So degenerative myelopathy, we should look in a different perspective. Instability is the cause of symptoms, and stabilization is the treatment. If you ask me one question, what is the most important issue in degenerative spine? Ask me. My answer will be, find out which levels are unstable. Find out, don't look at the image, yeah, unstable and osteophyte and treat like. Now this is 2 level of osteophytes. Patient presents with spastic quadriparesis. And I have done 4 or 5 level fixation. And you see the result after some time without any decompression. Why 5 level or 4 level fixation for 2 level issue. That is the issue in spinal degeneration treatment. You please read my article on the subject. Now this is 3-level issue. I have done 4 or 5 level fixation. You see complete clean after some months of surgery, no decompression. Magic is the clinical outcome. Mohammed told me to talk about atlantoaxial instability in degenerative spine. Nobody in the world has ever said that degeneration of cervical spine can be due to atlantoaxial instability. Nobody. Now look at this slide. Compression is here. Look at the facets. I do C1, C2 fixation and subaxial fixation without any decompression. When a patient comes on a wheelchair, when a patient comes on a trolley, atlantoaxial instability is almost 100% instability of atlantoaxial joint and subaxial instability. The treatment is atlantoaxial and subaxial stabilization, no decompression. And you please read my article where I have said so many patients came on wheelchair and so many patients are now walking. But now I don't include C1 facet screw in my fixation construct. I do a different type of fixation technique where I do C2-3, remove the C2 spinous process and then do fixation, no decompression, no inclusion of the arch of atlas and facet of atlas. So I retain the rotatory movements and this is my treatment. Now please look at this slide. Please look at, read this slide. This is a neurosurgical focus, no ordinary journal. Lumbar canal stenosis, analyzing the role of stabilization and futility of decompression. Such a huge statement to make in Journal of Neurosurgery. So this kind of multi-segmental, the whole world will do decompression. These are secondary, these are multi-segmental because of big weakness of your muscles. Stabilization is the treatment, instability is the issue, and absolute magic is the clinical result. So my answer is don't call it stenosis because it is a misnomer. In spine surgery, the focus is remove the osteophyte. Anterior surgery, corpectomy, discoidectomy, this focus is, or do laminectomy and make space for osteophyte. I am saying osteophytes are divine. I am saying osteophytes are good for you. Do fixation, osteophytes get. So you please read this article of mine in World Neurosurgery where I have shown what happens to osteophytes. These kind of osteophytes, there is no need for anterior surgery to remove this, laminectomy, laminoplasty, fix it and see the magic. Scoliosis, kyphosis, these are secondary. Kyphosis is secondary. Kyphosis is not primary or birth or embryological problem. It is due to unstable spine. Identify which levels are unstable and stabilize. Here I have done only C1, C2 fixation. Here I have identified central instability. I have included C1, C2. Here I have done only C1, only subaxial. You please read my articles. Another little bit controversial and unbelievable. I am saying disc removal is not necessary. I am saying disc is divine. I am saying disc is a reaction to unstable spine. You lift weight, you break your ligament, you make it unstable, disc is there. You stabilize the segments and there is no need to remove the disc. I am still studying this subject. You please don't go too much deep into this. Just see and enjoy prolapsed segment, prolapsed herniated disc, only stabilization. So this kind of disc herniation ACDF is a remarkably simple technique. There is no need to remove this. Stabilize this segment. This will disappear automatically. So this is my paper published in World Neurosurgery, Facetal Fixation Arthrodesis as Treatment of Cervical Radiculopathy. Similarly, we talked about lumbar radiculopathy, only fixation as treatment without removing the disc. My last chapter is from my French friend, OPLL. OPLL, the whole world thinks it is a problem. Whole world goes to remove corpectomy or decompression, the whole world. I am saying OPLL is divine intervention. It is protective. It is adaptive. It indicates unstable spine. Don't worry about this compression. Don't worry about this compression. Don't look at compression. Identify unstable spine. I was very good in corpectomy. For the first time, I described oblique corpectomy. But today, if you ask me, corpectomy is not necessary. Ossification of posterior longitudinal ligament, cervical spondylosis, same is the cause and same is the treatment. So this is my article which was published long time ago on OPLL, and about 5 years ago I published this article on 52 cases, only fixation as treatment of cervical myelopathy related to OPLL. So this kind of OPLL, don't do anterior surgery, don't do posterior surgery, don't start doing corpectomy and don't make a mess. I can bet whoever is doing OPLL and 3 or 4 level corpectomy, I can bet out of 10 patients you will have at least 2 people who have become quadriplegic. If you are saying they have not become quadriplegic, I will not believe you. If you do 5 or 6 level laminectomy, I can bet if you are doing 20 patients, at least 2 patients will become quadriplegic after surgery. If you are saying they have not become quadriplegic, I will say you are lying. You do only fixation without any kind of decompression and enjoy the magic. Suppose this does not work. Suppose you do fixation, it does not work. You can come and do decompression later, laminectomy later, after 5 days, after 2 months, or you can come from front and do decompression. I have never required to do any patient of mine any further decompression. This is the magic. So atlantoaxial instability is very commonly associated with OPLL. You have to include C1, C2 in your fixation construct. As I said, nowadays I don't do direct fixation of C1, C2. I do an alternative method of C1, C2 fixation. For this kind of OPLL, my dear friends, for me, I am 100%. Decompression is a negative form of treatment. Corpectomy and discoidectomy and OPL resection is a horribly dangerous treatment. Never do it. And you will just bleed in your head if you do yourself. So can atlantoaxial and subaxial cervical fixation, can it revolutionize surgical treatment of cervical myelopathy related to OPLL? My answer is clear. My answer is definite. And my answer is revolutionary, yes. And these are several articles that you can read in the literature. My concept is compression is never primary. Compression is never the problem. And decompression is never the treatment. Thank you very much.
Thank you, Professor Agol, for this nice presentation, a new concept and a new vision for spine surgery. Thank you. And now for the next and last presentation by Professor Aldea from Paris to tell us about the role of endonasal endoscopic approaches for CVG pathologies. Thank you.
Okay, thank you very much. So I tried to finish this excellent workshop speaking about the role of endoscopic endonasal approach in craniovertebral junction pathology. So it's quite late. I think everybody is a little bit hungry. So I'll go very fast through history. My previous hospital, Foch Hospital, has the privilege to be the first place where a surgeon tried to use an endoscope in transphonoidal approach in the 60s. But it wasn't followed because technology was still at its beginning. Afterwards, in Nancy, Professor Jankowski published the first series of pure endoscopic endonasal approach for pituitary lesions, followed by the known schools of Pittsburgh and Naples, and especially the professor who introduced me to this technique, Amit Kassam, who has a huge merit of introducing the modular concept in endoscopic skull-based approaches. So the modular concept involves a sagittal concept. Endoscopic endonasal surgery started for pituitary lesions, but quite quickly they expanded to transplanum, transcribriform anteriorly, and transclival and transodontoid posteriorly. There were also developments for treating lesions in the coronal plane, for cavernous sinus, for the petrous apex, for the infracarotid and the supracarotid area, for the infratemporal fossa. I won't insist on the anatomy. Professor Ben-Zagmut presented it superbly. I will just show you some tricks. When you look to the nasopharynx, you have to imagine where is the clivus. Actually, there is a simple landmark. The upper part of the porus tubaris usually is the mid-clivus. The pharyngeal tubercle is also a very important landmark, and I won't insist on this. It was very well presented. The pathology is also, my previous speaker had presented them. So let's see what are the advantages and the disadvantages. First, we should know that there are several variants of endoscopic endonasal approach that has been described: the transnasal, the transoral, and the transcervical. For myself, I have experience only with the endoscopic transnasal, so I won't treat the other subjects. So advantages: first, it's a natural corridor. When you look to the craniovertebral junction and you put an endoscope, actually you have already done almost 80% of the road. It's not a small disadvantage when you compare with extreme lateral approaches. It has an improved visualization, especially on the side. You have the possibility for craniocaudal and lateral extensions. You avoid fascial incisions, transmaxillar or transmandibular splitting, and also you reduce the risk of velopharyngeal insufficiency. But still, there are disadvantages. All endoscopic endonasal approaches are associated with a risk of chronic rhinitis, sinusitis, loss of smell, some degree of velopharyngeal insufficiency, even if studies have shown that is a lot less than the transoral trismus, and also you have less inferior extension. And for inferior extension, it's important to know these three lines: the palatine line, which gives you a straight direction to the lower limit of the clivus; the classical nasopalatine line described by Kassam, which is rather optimistic because in reality you never get your endoscope up here. It's otherwise you'll break the nose of the person. So more realistically, you should use this nasoaxial line, which chooses a point at the midpoint between the rhenian and the nasian, and this is more constantly your lowest point. It gives you the lowest point where you can get endoscopically. What are the indications? I think we had to know the limits of the skull base, of the midline and the lateral skull base. They are not quite well defined, but if you take two lines which go through the lateral parts of the cribriform plates, through the optic canals, through the cavernous sinus, the foramen lacerum, the foramen jugulare, and then to the condylar canal, basically these two lines defines your midline skull base, and I think this is the ideal playground for endoscopic techniques. There is a rule which Professor Kassam established already 20 years ago. You should not cross nerves. Cranial nerves do not like manipulation, so if you start to cross nerves by your technique, it's not a good idea. You can cross vessels, but on one condition: you have to know how to deal and really can deal with them. So I use several criteria, like previously said. Is it intradural, extradural? What is the location? Is the sagittal and coronal plane? What is the relationship to the major vessels? And Professor Goel showed a very beautiful example of vertebral artery going close to the midline. You should always know that the cervical ICA also can do loops, like in this case, where the loop was very close to the midline in the C1, C2 area. Previous surgery and radiotherapy also are criteria. You don't like to return in a previous site which was operated and irradiated. And of course, surgeon's experience and preference. Why? Because it's a steep learning curve. Dural closure remains a major issue, and postoperative CSF leak rates were reported up to 20%. Although that CSF diversion, like external lumbar drainage, may lower this rate. So to summarize, the indications are quite simple for me. If the lesion is extradural, midline, has no major vascular relationship. If the patient had other posterior or posterolateral approaches, he was operated and irradiated, I would favor an endoscopic approach. If the lesion is intradural, has a large lateral extension and has major vascular relationships, I will favor a microscopic approach. But, as we say in French, exception to the rule is rule. Let's see some example. And I think the endoscopic approach, you should think about it when all the other techniques seem impossible. This is a 63 years female who came to us almost completely hemiplegic. She had like 15 bleeding episodes in the previous 5 years, and she was refused surgery almost everywhere. So, well, in this case, I agree, you don't have very much techniques that you can offer this lady, but you can offer her an endoscopic endonasal surgery with quite a simple transclival approach. You have a very direct line to this line of approach to this lesion, and this is a postoperative MRI. The patient was identical. She didn't recover the hemiplegia, unfortunately, but it was already installed for 5 years, but she didn't have any other bleeding episode afterwards. I will show some example. I will skip the odontoid removal. I don't think it's very interesting. I will show you an example of a temporopetroclival epidermoid cyst. This is a 39 years old female which had been operated 20 years ago by my mentor, Professor George, for a CP angle epidermoid. So she came emergently for hemiparesis, hemianesthesia, and hemianopia with this huge temporopetroclival epidermoid cyst. I operated on her for the supratentorial part through a transsylvian transtemporal approach, so I could obtain a quite good removal of the supratentorial part and even access through the tentorium to the posterior fossa part. You see that it's in part partly removed, but there is still a lot of tumor. Afterwards, she refused the second step surgery, but she came back 3 years later with swallowing disturbances, with balance difficulties, and an epidermoid which was clearly enlarged, and hydrocephalus. So you can see that the tumor is infiltrating the brainstem. I really don't know what other approaches that you can offer except an anterior approach. So we operated her through a transclival approach, and we obtained a quite good result. I will speed a little bit. This is still the preoperative MRI. And after surgery, this is a postoperative MRI where you see there is almost no more diffusion hypersignal, and the brainstem had recovered the initial position. It looks like a success story, but I say you should remain humble. This patient stayed only 7 days in hospital. She returned 3 weeks after singing in the church, Hallelujah, with a huge pneumocephalus, and afterwards hell began. She stayed for 4 months afterwards, and I had to evacuate multiple abscesses. What I didn't know then, and we know now, is that epidermoid cysts have a larger rate of infection through the endonasal approach, probably because the membrane is avascular. So when you get a germ on this membrane, infections are more difficult to treat. Still, I don't know exactly how else I would treat this patient now. And this is my last example. This is an anterior foramen magnum and lower clivus meningioma. As I told previously, I favor the far lateral approach, but still there are cases when you need to think about the interior approach, because this is a purely anterior approach with a lesion which is getting inside the brainstem. So I don't think you can get it from a lateral approach, especially knowing that, in my experience, all foramen magnum meningioma are firm. I've never seen a soft suckable foramen magnum meningioma. So this is the endoscopic approach, right middle turbinectomy, middle meatotomy in order to store the nasoseptal flap, because you need to go down, so you cannot store the nasoseptal flap in the nasopharynx. So this is the dissection of the nasoseptal flap, which is pushed laterally. We remove the posterior part of the nasal septum and of the vomer. We drill the maxillary crest of the palatine bone, which improves the access inferiorly. This is the second flap. It's a mucopharyngeal flap, which is inverted. It's a new inverted. We need to drill the floor of the sphenoid sinus. Afterwards, drilling the clivus between the two paraclival carotids. When you remove the last eggshell of bone, you have some bleeding from the basilar plexus. You check your exposure with neuronavigation, and afterwards you open the dura. This also can, you may have some bleeding from the basilar plexus, but usually you can manage it by bipolar and flow seal. And you have the upper part of the tumor. You can already see it's a very firm tumor. And this is the left 6th cranial nerve, which can be dissected on the upper part of the tumor. Afterwards, it was like 3 hours of debulking because CUSA, even at maximum intensity, it worked like this. You can see that it's not very efficient, but you have to be patient and dissect, debulk. And slowly you can reduce this mass and dissect the tumor and pull it inside the sphenoid sinus. Still, you need some more debulking with scissors and CUSA. And I think this is a step when the tumor finally is dissected and it can be more largely debulked. This is the last sector dissecting the bulbomedullary, the pontomedullary junction. And finally, the lower aspect of the tumor, which is dissected. On the end, you have all these exposures, bulbar pyramids, the left vertebral artery, which was displayed to the right. Well, closure. Closure is very important, and what I use in this case, I use a fascia lata suturing with a technique which was described by Japanese colleagues with what we call the sliding knot technique. It's quite time-consuming because you need like 4 or 5 minutes for every knot, but you can obtain already this result. It's almost watertight after the suture of fascia lata. The nasoseptal flap and the nasopharyngeal flap are more a supplementary security. So you put back the flap, you put some Surgicel, some glue, you fix your flaps, and afterwards you put a urinary catheter like a counter pressure. We used an external lumbar drainage for 4 days. There was no rhinorrhea. She had a complete left 6th cranial nerve palsy, but she recovered at 6 months, and the post-operative result was satisfactory. And this is a final quiz. So this is a patient which came with left trigeminal paresthesias. So I would like to know the opinion in the conference room. What would you do? And my question is, what surgery was done between the left and the right? The patient was operated. We agree there is a Chiari and a Syringomyelia. Can hear? Very good. I did just a third ventriculostomy. 10-minute surgery. That's the result 1 month after. It was 10 years ago. Incidentally, I saw him 10 days ago. It's the same result. So what I want to give you as take-home message, there is no universal truth. Things are very complicated in the craniovertebral area. That's all. Thank you.
Merci, professeur Aldea, pour votre très intéressante présentation concernant l'apport de l'endoscopie dans les pathologies de la charnière cervico-occipitale. Maintenant, la discussion est aux auditeurs. On a 15 à 20 minutes de discussion. La parole est à vous.
I would like to thank all the speakers for this session. And I have a question about post-operative course, mainly the length of stay in ICU for these patients. Can you tell us about your experience?
So first, I'd like to say I'm going intradurally only if I'm fully convinced that there is no other way. So, for instance, I've operated like, I don't know, maybe 40 or 50 foramen magnum meningiomas. I used endoscopy only in 2 cases. When I'm convinced that I cannot get sufficient exposure through a posterolateral approach. So my standard, actually, you know, one of my teachers always told me, le traitement des ennuis est prophylactique. You treat, the treatment of complication is prophylactical. So I think CSF leak is the main issue. So whenever you can do the suture, it's really a pain in the ass, to speak plainly. To do 6 knots, you need like half an hour. You're tired, you're at the end of the surgery, but I think this is the best investment of the post-operative course you can do, because if you have a good closure, actually the post-operative course is nothing. It's nothing. So post-operative course, it's the closure. Afterwards, I use external lumbar drainage. That's systematical because there is a randomized trial published by the Pittsburgh team which shows that you diminish the rate. I'm not very convinced, for instance, for craniopharyngiomas or for suprasellar meningiomas, I don't do it anymore. So I think in the clival area, it's a difficult area to close, so I still use it.
Thank you, all the speakers. One question for all. What could be the contribution of the echography, the per-operative echography and neuronavigation, especially for young neurosurgeons?
For the Chiari?
The vertebral artery.
Ah, for the vertebral artery?
Yes.
As I told earlier, neuronavigation, I think it's a pitfall. I've seen many people, I think it's true for all skull-based surgery. I've seen some surgeons get 2 millimeters inside the ICA thinking they are 2 millimeters outside, given on the neuronavigation. So I don't rely at all on neuronavigation. I think whenever you have a tumor which has vascular encasement, Doppler is more reliable, and anatomy is much more reliable. It's like in the clinoid meningiomas, you have to do a clinoidectomy to know where your clinoid ICA is. I think it's the same for the vertebral artery. You have to dissect your vertebral artery to have proximal control. I don't know if Professor Goel...
You know what my concept is. And I appreciate your, means I'm not trying to argue. This dura is a very fantastic material. Dura is dura matter, dura mother. As I was talking to Muhammad the other day, dura mother. On one side of the mother is the sterile brain, is the completely bacteria-free, organism-free brain. And on the other side of the dura, other side of the mother, is a zoo of animals. Hundreds and thousands of bacteria and organisms are there in the nasal cavity. So this dura. My concept is, for any tumor which is on this side, of the brain side of the dura, I like to do transcranial operation, and whichever tumor are on the zoo side of the dura, I like to do nasal operation. This is my concept. I like to do transnasal surgery for tumors like pituitary tumors and chordomas. But I am entirely and completely against, means I am absolutely against doing surgery for tumors like foramen magnum meningiomas, for epidermoid cysts, for tuberculum celli meningiomas, which are on the other side of the dura. Any nasal operation. No matter how good you are in your closure, your CSF leakage and all those things, but it is not necessary, in my view. Of course, now we see so many people talking about endoscopic use for tuberculum celli, for epidermoid cyst, particularly epidermoid cyst like a tumor, which has such a wide extension. To do any kind of nasal exposure, you have to drill the whole of clivus. I have got the largest experience in the world in epidermoid cyst. I can say this nasal approach is a complete, absolutely not a good operation. Nasal approach for foramen magnum meningiomas, absolutely and completely not a good operation. Nasal approach for tuberculum celli meningioma of any kind. I know there is literature. I have read hundreds of papers. They say I do transnasal, I do this, and I do for tuberculum celli meningioma in my view. I'm not saying about your